Good morning, distinguished ladies and gentlemen. It's my pleasure to welcome you to this distinguished meeting organized by the Ibadan Medical Specialists Group, the UK, Imsg-Uk. Like I told the president, incidentally, this is the 30th year anniversary because IMSG came into being in the year 1995. So let's give them a round of applause, please. It's significant to note that IMSG has not just been a pillar of support, but they've been a continuous pillar of support. They've been supporting the college annually since 1995. Please, let's clap for them again. My name is Bola Obajimi. I'm an obstetrician and gynecologist, and I'll be declaring this meeting open. I'm your Masters of Ceremony. I'll be starting by taking the anthem. So please, may we rise. BCC, please. Anthems. National anthem, please.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign fatherland.
You may please be seated. I'd like to welcome members of the High Table and dignitaries with us. This meeting, though chaired by the Vice Chancellor in absentia, we have with us, representing him, the Deputy Provost of the College of Medicine, Professor S.B. Olale. Please let's give him a round of applause. And on the high table is the financial controller, Mr. Ayoni Shino. You are most welcome, sir. And then we have next to him the president of Imsg-Uk, Dr. Bode Williams. Let's give him a round of applause. And the education secretary, who has interacted with most of you, I know, Associate Professor Oladejo Olale. Let's give him a round of applause. Having done that, I would like to welcome Dr. Olale to please introduce members of his team. So the Education and Research Secretary of IMSG, you are most welcome, sir.
Good morning, everyone. I'm Dr. Oladejo Olale. I'm a consultant in ENT, head and neck and robotic surgery at the University Hospitals of Leicester, UK. I'm an honorary associate professor of the Leicester Cancer Research Centre in University of Leicester, and I serve currently as the Education and Research Secretary for the Ibadan Medical Specialists Group, UK, that is putting together this symposium today. It is a real pleasure to be here today, and I really want to thank everyone who is here present and our colleagues who are joining online on Zoom. You're all welcome. The symposium is a flagship of IMSG. We come here every year. I still remember as a student, this is about you, students, okay? This is all about giving back and supporting your education, supporting training in Ibadan, supporting our colleagues in Ibadan. I still remember very many years ago when I was sat at the back in one of the symposiums, and Mr. Banji Adeyoju, he was talking about laparoscopic, surgery for the kidneys. And I looked at it and thought, wow, I'd like to be like this one day when I grow up. So there's some of you in the room who are thinking, okay, you're thinking about your career and what you're going to become. You're going to be great. You're going to do great things. And it all starts from a dream. Your dreams are valid. You work hard for it. You believe for it. God opens the doors for you and you will shine. So, I know the students who are here at UMSA. It was great to meet with the UMSA executives last night, led by Folusho and the team. We had a really wonderful time. Oh yeah, they're clapping. Yes, so we had a really good time together with the IMSG executives and ICOMA executives, and it's about breaking those barriers. There are no dividing lines between us. We're all one and the same alumni, students of the great College of Medicine, Ibadan. So last night we had a good time. We talked, we played chess. There's some future grandmasters in their midst there who gave me a good run for my money. But today is about the symposium, and we are here to talk about something important, emergency medicine. And there's a huge burden around emergency medicine care in Nigeria. From trauma to sepsis, infections. So we have a fantastic lineup of faculty who will be presenting today on the theme of emergency medicine. And I'm just going to mention their names. So really, really grateful to have Dr. Kehinde Ojifini, who is the emergency medicine lead for UCH Ibadan. Kenny Ojifini has been fantastic. We've been collaborating strongly with the team here in Ibadan on their priorities and how this should go. And we're grateful to him for organizing the postgraduate team as well. We intend to have 2 sessions. We'll have lectures in the morning from our faculty, and in the afternoon, we intend to have skill stations, so practical skill stations where students and residents and postgrads can actually practice some of these skills we're talking about: cardiopulmonary resuscitation, basic life support, advanced trauma life support, sepsis role play. That is what we intend to do. So it's been great to work with Dr. Kehinde Ojifini, who is our local collaborator, to put this together. We're going to be listening to basic life support by our Professor Lagunju, who is here present, who is our, yes, please, a round of applause for her as well. There will be a talk on advanced trauma life support by Dr. Kayode Adeboye, who is a consultant emergency medicine expert from the UK. We have all the way from America, our emeritus professor, Olugbenga Kingbola, who will be presenting pediatric shock and septic shock. Adult sepsis will be taken by Professor Rotimi Jayesimi. Round of applause for him. He will be presenting live online on Zoom. So hopefully we can have that session. There will be a talk on airway management, non-surgical airway management by Dr. Adegboyega Akintude, who's also an emergency medicine expert in the UK. He will be presenting online as well. A round of applause for him, because I know he's currently online and watching. And there will be a talk on airway management, surgical airway management, by myself. I'll be talking about tracheostomy, cracothyroidotomy, which is what I do often to help patients with airway difficulty. We would hope to have a meeting in the afternoon with our scholars and from our global sponsor, a student program. We've got the leadership here present. Dr. Olabisi Oshikanlu and her husband are here present. She's also flown in all the way from the US to be with us today, so this is really special. We have Professor Adeshino, who was here for the photograph. She's probably just, oh, yeah, she's right behind me. Please, a round of applause for Prof as well. And Dr. Adebayo, please, a round of applause for her, who coordinates the GSAP. So yeah, we're really grateful to all our faculty. In the afternoon, the skill stations will be coordinated by the director for skill stations, Professor Temitokwe Alonge. I believe he will be around. I can't see him in the auditorium, but he'll be here. There will be mannequins where students can practice cardiopulmonary resuscitation in the afternoon. Basic life support, advanced trauma life support will be taken by our Professor Temitope Alonge, please. Oh, it looks like him. Sorry. So in the afternoon we would have airway skills management, sepsis management. There will be some role play. So we would have our postgraduates role play some of the critical things that our faculty will be talking about. Sepsis, how did they respond to that? Trauma, hypovolemic shock, and hopefully the undergrads can learn from that as well. We will do all of that in this auditorium. We'll put the mannequins in front. And I think, we would go through sessions of question and answer at the end as well. We're really grateful to the College of Medicine, Ibadan. In particular, the provost, Professor Temi Dayo Gundinron, who is not currently here present, but he's well represented. We had the pleasure of meeting him yesterday in the provost office, and we had really great deliberations. IMSG was here yesterday commissioning a solar panel project for the academic hub, and we're grateful to everyone who was present. We believe this will support research and education in Ibadan, both for students and for postgraduate residents who are training and doing research. We're grateful to Professor Mokodion, President of ICOMA Worldwide. We've got our ICOMA Worldwide Vice President here himself, Dr. Bajimi. Please, a round of applause to him. And I really want to say a very public thank you to Dr. Bajimi, who's been instrumental in helping to put together this symposium. So we're really, really grateful to him and the team. So a round of applause for him. And I think with all protocols duly observed, I'm going to call on the president of the IMSG. Yeah. So it's my pleasure to invite Dr. Bode Williams, who is the president of the Ibadan Medical Specialists Group, UK. He's been a fantastic leader. I like his style of leadership. He's collaborative. He carries the team along. He's really down to earth. He's one of us, and it's been great to see how he's led and how IMSG has flourished. So a round of applause for Dr. Bode Williams. So in closing, I'm really grateful to everyone, every single member of the team, the faculty, the students for turning up, the College of Medicine, the UCH. We're grateful to the UCH as well. And we're grateful to all members of IMSG who are online, who have supported the program, who continue to give. We see you, and we're grateful to you. Dr. Adeyoju, Lady Helen Sasegbon, we see you guys, and we're really grateful to you all. And finally, I really want to say thank you to my wife, Dr. Jaye Olaleye, and my two daughters, Ruby and Lily, who are also watching. Jaye was also a student. We were students together here in Ibadan. So with that, I'd like to hand over to Dr. Williams, who also met his lovely wife, Dr. Bims Williams, who's also in the house in Ibadan. Please come on.
Distinguished Provost, ably represented by the Deputy Provost, distinguished President of ICOMA, ably represented by the Vice President of ICOMA worldwide, faculty officers, faculty deans, the distinguished Chief Medical Director, ably represented by the Chair of CMAC, the college management officers, UCH management team, distinguished speakers, respected colleagues from Imsg-Uk and the Global Student Sponsored Student Program, students, guests, good morning. My name is Bode Williams. I'm the president of Imsg-Uk, and I'm a consultant obstetrician based in Liverpool in the United Kingdom. I warmly welcome you to this year's annual symposium and homecoming activities. The question is, why emergency medicine? Why have we chosen this as? I think it's this theme couldn't be more vital and timely. In moments of crisis, when every seconds count, it is the knowledge, preparedness, and the skill of a clinician that determines the difference between life and loss. Today's program is alluded to by Professor Dejola, spanning across life-saving basics to advanced critical care interventions, which reflects and reinforces our commitment to sharpening clinical practice, expanding capacity, and our commitment to advancing medical education. We at IMSG have a steadfast commitment to advancing education, supporting academic systems, and fostering collaboration with colleagues at home and abroad. And today's collaboration with the University College Hospital emergency team exemplifies what can be achieved when expertise and dedication come together and cross borders for the greater good. As Imsg-Uk, we will continue to support and advance medical education, and we feel that we're building a foundation that would outlast us and ensure that the next generation of doctors are better inspired, better equipped, and better supported. I was asked this question by some of the medical students yesterday. Now, who are we? Who are Ibadan Medical Specialists Group UK, and what is our mission? And I explained very simply that we're graduates of this prestigious medical school who are based in the United Kingdom. And for 31 years, we have embodied excellence, integrity, and inclusiveness. And I think we're proof that a small group of committed alumni can make a tangible impact on their alma mater. That spirit, the collegial spirit that we have in Imsg-Uk, continues to guide us as we continue to support our student and alma mater to excel as doctors. We have grown from a small group to a thriving network of alumni dedicated to supporting and advancing medical education and academic systems. We began with founding members were 7 visionary alumni. That's what I call them. These are pictures of 4 out of 7 of them who were driven to putting something back to this great university. And since then, we have grown. These are pictures of presidents past and present. And these are pictures of our group. We're just ordinary folks. The picture on the left of your screen is a members meeting with Professor Akonde, Foundation President of ICOMA Worldwide. This picture was taken about 25 years ago after following the members meeting. And the picture on your right is the picture of a protocol of general of members with their spouses at an annual general meeting last year in the beautiful surroundings of Rutland Waters. These are pictures of our members and supporters from a fundraising event which was highly successful at the Trafford Cricket Ground 2 years ago. Over the last 3 decades, IMSG has contributed meaningfully to the academic systems and infrastructural growth of this great institution. What I'd like to say is that our achievements are not just milestones, they are or signify the collective generosity, teamwork, and the shared purpose and value of Imsg-Uk members towards advancing education. In 2015, that's 10 years ago, we built and equipped the iconic preclinical library. Two years ago, we refurbished this lecture theater. These are pictures of our members with the ICOMA president, ICOMA vice president, Professor Migodun, at the opening and refurbishment, and then Professor Gundaron, the current provost, and pictures of our executives with scholars, IMSG scholars at the time. IMSG is also leading the way in renewable energy solution. Last year, we installed solar-powered at the Anatomy Library, and the students have told us this has been a game changer. Yesterday, we commissioned the solar-powered workspace at the College of Medicine here at the UCH campus. We believe this infrastructure growth will ensure there is steady electricity, internet access, providing an enabling space for lecturers, staff, students to conduct research, collaborate, innovate, and prepare for teaching. IMSG has a rich academic legacy. I've just been told now by Dr. Obajimi that we have been hosting annual symposium at this college since 1995. So this is the 30th year we've been holding annual symposium. Okay. Since 2001, we have published specialty themed textbooks every year between 2001 and 2021. These are just samples of some of the texts we have published in collaboration with experts both here and abroad. So it's been great work of collaboration. And then in 2021, we launched the Journal of Global Medicine to ensure that cutting-edge research and best practice updates are available online for free. IMSG is all about our members, and these are the brilliant research and education secretaries through the years who have been responsible for this forward momentum. I just have the pictures. You might recognize many of them at previous years. So these men have been very brilliant. They've been great collaborators, and they have been responsible for our rich academic legacy. I think IMSG are proud to be benefactors of the Global Sponsor Student Program. And it's truly it is inspiring and uplifting when I receive news, joyful news of the sponsor students being awarded distinctions in their exams and also graduating as doctors. And I can see the impact of our collective efforts and the vision behind this program. And I would like to extend my sincere appreciation to Dr. Shikalu for exemplary leadership. Professor Adeshina, Dr. Bose Diafolebele. I think this program is an example of great collaboration, and the impact has been great. So we are proud to be part of this. We also have an active engagement and collaboration with Imsg and medical students. We're deepening this collaboration, which was exemplified with our dinner with them yesterday. It was really, I really enjoyed it. I was really impressed by the Imsg executives, well led by Folusho Oluwadegbola. You guys are really talented, and I would like to reaffirm IMSG's commitment to supporting your innovations, your student welfare programs, and your professional excellence activities. So we're really committed to supporting your activities. Fundraising is integral to IMSG activities. In the last 3 years, we have raised over £30,000 through charity treks, challenges, and fundraising events. And in February 2025, the IMSG team conquered Mountain Kilimanjaro, the majestic mountain. And that was no easy feat. It's a historic expedition. And some of the fellow team trekkers are here. My darling wife and Dr. Biodun Abiyoye. Before that, we had to practice. It wasn't easy. So we did the practice 2 years earlier by scaling 3 of the highest mountains in Yorkshire region in the UK. Those are the trekkers at the time. Again, we raised substantial funds towards the sponsored student program. So I just wanted to show, that slide didn't show, don't worry. So I was just going to show a slide of fundraising activities, but that won't show. And these are the current executive team. These are the team, my executive team. They've worked incredibly hard. They're all brilliant. We work as equals. And 4 out of 6 of them actually present here today. And so I'd like you to recognize the presence of Dr. Abel Adegoke. He was actually the commencement speaker. He's a motivational speaker, actually, at the program yesterday. We have Dr. Biodun Abiyoye, the vice president. We have Professor Dejola Laye, who needs no introduction, the research and education secretary. We have Dr. Femi Adebajo, who is not here with us, but he's probably here online supporting us. He's our Secretary General, and we have Dr. Tolu Lokpe Ogumoko, the Assistant Secretary General, who are probably both online in the United Kingdom. And I also wanted to acknowledge the presence of some of our members. I have Dr. Kayode Adeboye, who's our lead for emergency medicine faculty. He's one of the brains behind this symposium, so putting it together. I really appreciate you. We have, some members might turn up. Dr. Olufemi Oluwatayo is here as well. He's a traveling IMSD member. Thank you for being here, Femi. And then we have my darling wife, Dr. Abimbola Williams. Okay, so how do we get this back? What I wanted to, this next slide is just showing that we the backbone of our mission is collaboration, our members and the partnership that we have. We have a strong partnership with this college here, with ICOMA worldwide, with a global sponsor student program, with UMSA and other alumni bodies. They're the backbone of our mission, and it's through these collaborations that we're able to accomplish many of our mission and support the students, support the alma mater. So I want to thank everyone who has contributed and made most of our milestones possible. And then I just wanted to, I'm not sure if this will play. This was a video of day 4, I don't know how to get it on, in Kilimanjaro. It's a very short video clip. The sound is not there. What? Yeah, okay, let me increase the speaker sound. Over 7-day climb. That was when classes began to set in. Our path came very steep. The air was thick. And step by step, we continued to make progress on day 4 when we were all getting very tired. And that expedition reminded me that progress really comes easy. It was through faith, through teamwork and perseverance, we reached the summit of this majestic mountain. I believe in the same way that IMSG continues to support one another, support our students, support our alma mater, we can surmount any challenges, we can rise to any challenges. That's the important message. I think together we can transform lives, we can scale new heights, we can enable tomorrow's doctors. I'd like to thank you all. Thank you all for your collaboration. I fondly believe that progress is made through service and partnership. You're not going to achieve much if you're trying to do things on your own. And without all these great collaborations here, many of our milestones achievements would not have been possible. I want to thank you all for your attention, and thank you all for being here.
Thank you very much. Let's give a round of applause. We're going to move very quickly now. Time is fast spent. But before that, I just want to quickly recognize in our midst, formally, the representative of the Chief Medical Director, who is the CMAC herself, Professor Olubukola Deshinoma. You are most welcome. Yeah, thank you. Our dear College Secretary and Deputy Registrar, Mr. Emmanuel Odedele. Sir, you are most welcome. And importantly, we have the representative of the Bossa of the University of Ibadan. This is the first time we're going to have that here. And we have with us a very special guest, Alhaji I.O. Popola, who is the Deputy Bossa of UI. Thank you very much, sir. Thank you, sir. And of course, while the program was going on, the president of the Ibadan College of Medicine Alumni Worldwide, Professor, Emeritus Professor Samuel Omokojo, walked in. Sir, you are most welcome. Our medical librarian is also seated. Ma, you are most welcome, ma. I almost did not spot you. Thank you so much, ma. And the Secretary General of ICOMA Worldwide is somewhere in the audience. Dr. Tijani Shitu, you are most welcome. So I'd like to quickly invite for a very brief welcome address. I want to reduce the addresses now to 5 minutes so we can finish on time. This is a veto power conferred of the MC, conferred on me, and I'm going to use it. So I'd like to welcome our dear teacher and president of Ibadan College of Medicine Alumni Worldwide, Emeritus Professor Samuel Omokojo, to please give a welcome address. Sir, you're most welcome. Let's keep clapping.
Thank you. And for time, let me stand on the very well-established protocol already. Not without, of course, acknowledging the provost represented by the deputy provost this morning. And first, let me begin with an apology. Sometimes when stories of this nature are told, it's difficult for persons to believe them. I had been invited as speaker at our annual general and scientific meeting, which was holding in Lagos. And I decided to skip a day of the conference and leave early so as to come over back home to see that things were in place. Thank God we acted earlier. I spent 9 hours on the express road yesterday. From the time I left my hotel at 10 a.m., I got home 7 p.m. And of course, that's cascaded to affect every other thing, right through till this morning. And therefore, I want to specifically apologize to the president, executive, and members of IMSG that I was supposed to be with you yesterday on 2 events, which I left specifically for, but I was on the express road. I wish I tried to, if I had known, I would have put a web connection so I could join you on the express road. But that said, IMSG has become a household name not just in the College of Medicine, but in the University of Ibadan. And you have just been treated to some of the reasons why. That's not an exhaustive list. And I know the president is very modest in his ways. But there is no time presently to go on and add all the others. But believe me, IMSG has become one of those organizations that is bringing to reality, and I want to quote Professor Wole Soyinka, who said the African, in the average, when he comes across a mountain and he cannot surmount it, they worship it. But the other average persons, by which he meant the Caucasians, when they find a mountain that is in the way, they do everything to surmount it, and when they can't surmount it, they tunnel through it. IMSG is one of those organizations that's changing that narrative and bringing to our people who do not take no for an answer. People who are not looking for reasons why things cannot be done. They believe we can and we should. And IMSG is one of those organizations that's changing the mindset and setting that narrative in our people, in our generations that are coming. Let me just take a few lines from my one-page prepared script. It is therefore with immense pleasure and delight that I extend a warm welcome to all members of the Ibadan Medical Specialists Group, United Kingdom, both those who are present here in person and those joining virtually for the 2025 Homecoming Week of Activities. IMSG has certainly, consistently shown unwavering commitment to support educational advancement, research, and clinical innovations at the College of Medicine, University of Ibadan since its inception. Each year, your group has delivered significant projects that have had a lasting impact on our institution. Some of the notable accomplishments, again, you have just been treated to them. I don't need to enumerate them any longer. And this year has been no exception, as you have just heard. Yesterday, as part of this homecoming week of activities, a 10 kVA solar-powered system was generously provided by your group and was commissioned. Additionally, you have organized symposia addressing timely subjects relevant to learning needs of students, residents, and senior colleagues alike. This year will also be a similar treat. These remarkable achievements are a testament to your generosity and steadfast dedication to the ongoing upliftment of our alma mater. Your efforts continue to enhance the college's stature and contribute meaningfully to its continual progress. We eagerly anticipate the renewal of old acquaintances, the fostering of mentoring opportunities, and the chance to gain a first-hand appraisal of the true situation on the ground. With the collaborative efforts of ICOMA and Imsg-Uk, we celebrate the steady advancement of our beloved institution in every respect. I congratulate the visionary leadership evident within IMSG always. Wish you all an enjoyable homecoming week. May your journey back to your respective places of residence be safe, and may you continue to achieve great strides in your respective career paths. Our prayers are with you for continued success in all your endeavors. Thank you very much.
Thank you very much, sir. Very briefly, I'd like to invite off stage the representative of the Chief Medical Director of the University College Hospital, the Chairman Medical Advisory Committee, Professor Olubukola Adesina, for a short remark. Please, let's give her a round of applause.
The provost and other principal officers of the college, here ably represented by the deputy provost. On behalf of the chief medical director, Professor J.C. Abiodun Otegbayo, is on an assignment now on affairs concerning the hospital, and our management, our staff, students, and our patients. I want to warmly welcome IMSG and the leadership. Allow me to also welcome the leadership of ICOMA, our Emeritus Professor Omokodio, the GSAPS family, and our students. Please indulge me if I welcome my classmates. Bode, Bimbo. Yes, please stand up. Don't be shy. And Springy. Yeah, we call him Springy. Please also allow me to welcome specially Dr. Shikalu. She was here just now, and I better half. They've come thousands of miles to be here with us. I welcome us all to this Imsg Symposium. Dr. Bajimi, 2 minutes, don't worry. There are so many reasons to celebrate today. And I just think it's a day to celebrate. Honestly, celebrate IMSG, celebrate ICOMA, celebrate the College of Medicine, the GSAPs, the faculty, the students. There are so many reasons to celebrate. Because today, this signifies giving back. There are so many reasons. Capacity building. We are building dreams. We are impacting on others. We are ensuring that dreams don't die. The demonstration of generosity, a demonstration of empathy, a demonstration of what you can do when you have opportunities, a demonstration of collaborations and partnerships from sleeping. They're the things that you keep thinking about. I can get there. It is possible. We will tunnel through that mountain. Yes, there are challenges, but I do believe tough times don't last, but tough people do. We will come out bigger, better, and stronger on the other side. And that is what we are celebrating today. That perseverance, that belief that yes, we will be there. The University College Hospital has the mandate of training, clinical services, and research. I always say the reason we're here is because of the students. If the students are not here, then we become a specialist hospital. We are no longer a teaching hospital. We'll become a federal medical center. And that is key, training. That is the core mandate of the hospital. And what IMSG is doing, what ICOMA does on so many platforms, what you're doing is ensuring that the University College Hospital is able to achieve its mandate. And so we are always willing and ready to partner with everybody who comes on board with us for that. They call us the first and the best, the premier teaching hospital. Like I always say, we do not take that lightly. Sometimes it may seem as if we are not there, but we do believe that, yes, that we are there and will continue to be there. We don't take that responsibility lightly. And so we thank you so much, IMSG, and every other person who partners with us. The hub and the symposium, like I said, contributes to the training. And it's also what the mantra of the CMD, which is patient satisfaction and staff welfare. That is what you are doing. With what you are doing here, what you did yesterday, what you continue to, and what you believe that you continue to do. That is what you are doing. You are feeding into the mantra. And so once more, on behalf of the Honorable Minister of Health, Professor Mohammed Ali Pate, the Chief Medical Director, the management, our staff, students, and patients, we welcome you once more. We thank you very much, IMSG, for this opportunity, and we look forward to more partnerships and collaborations with you. Thank you so much.
Thank you very much. Keep the applause coming. Thank you. To give the chief host's address today is no other than our amiable Provost of the College of Medicine,
ICOMA executive. You're welcome, sir. And sorry for the trauma that you encountered yesterday. It's one of those things about the Nigerian road. And the president of IMSG-Uk, and other members of the ESCO. I will not forget to appreciate the presence of our CMD, represented by the CMAC, and also the MC said Alaji Pokola is coming to represent the BOSA, and this is the first time the BOSA is going to be represented in an IMSG program like this. I think we need to appreciate that. It is not a coincidence that the person that was sent by the BOSA is a friend of the College of Medicine. I know the reason why I'm saying that. I was Dean of the Faculty of Basic Medical Sciences for 4 years between 2018 and 2022. And in conjunction with other deans, we had to go to his office to get some money that was hiding in the main campus of the University of Ibadan. And he played a significant role in extraditing that money to the College of Medicine. We appreciate you, sir. let me also recognize the presence of the director of the University Health Center, Dr. Aderonke Ajav. You are welcome, ma'am. Yes. The Vice Chancellor and the Provost are in a program that we all know at the International Conference Center for the convocation ceremonies. That's the reason why they are not here. And also today is a very packed day for programs. After this program, around 2 o'clock, the Court of Governors of the College of Medicine will be meeting. It's like the council of the College of Medicine. So everything is lumped together. And there are other programs that have been put off even before that time. So the Provost and the Vice Chancellor sends their apology for not being able to be here. But I was told to deliver a message, and that message I will read. The Provost said it is his pleasure and honor to welcome you all, physically and virtually, to the 2025 Ibadan Medical Specialists Group UK Homecoming Symposium. This year's theme, Emergency Medicine, resonates well with the mission of the college to prepare generations of healthcare professionals who can respond swiftly, intelligently, and compassionately to the urgent needs of humanity. In the face of rising health emergencies, from epidemics and trauma cases to humanitarian crises, our readiness, our competence, and our commitment are true measures of our medical calling. Today's symposium stands as more than a meeting of minds. It is a reaffirmation of our shared purpose to save lives, to innovate, and to lead. The array of distinguished speakers, experts in life support, trauma care, sepsis, management, and airway control demonstrates the richness of our collective expertise. I am confident that the insights exchanged here today will further sharpen the skills of our clinicians and inspire a new generation of emergency medicine practitioners. But today is also a day of gratitude. The College of Medicine, and indeed the University of Ibadan, is deeply moved by the continued generosity and vision of the Ibadan Medical Specialists Group UK. Your recent donation of an academic and training hub powered by sustainable solar energy represents far more than a physical structure. It is a legacy of hope, an enduring symbol of what is possible when dedication meets purpose. I believe the president had given us an array of those things that they have been doing, and I can attest to this fact. As the secretary of the Ibadan College of Medicine Alumni Association some times ago, I'm talking about myself now, I witnessed a lot of things that IMSG did to the College of Medicine. And last year, I remember in anatomy department, we were there to commission the solar powered system that the students have been using till today. We can also talk of the IMSG library that is serving generations of students in the preclinical group. We appreciate you, IMSG. The hub that was commissioned yesterday as one of the highlights of this year's event will enhance how we teach, how we learn, and conduct clinical training. It will enhance our productivity, even in the face of incessant epileptic power challenges. It stands as a testament to your belief in the future of medical education in Nigeria. For this, the College of Medicine, and indeed the entire University of Ibadan community, express our heartfelt appreciation. The collaboration between the college and Imsg-Uk exemplifies the power of unity, the unity of purpose between those at home and those abroad, between vision and execution. You have shown that true service transcends geography and that excellence, once nurtured here in Ibadan, continues to shine across the globe. As we begin today's deliberations, I enjoy every participant, faculty, residents, and students to fully engage, to learn deeply, and to share openly. Let this symposium not only equip us with skills, but also reignite our sense of duty to humanity. On behalf of the College of Medicine, University of Ibadan, I welcome you once again to this landmark event. May today's proceedings inspire us all to greater service, deeper compassion, and renewed excellence. Thank you, and God bless you all.
Thank you so much, sir. Thank you. At this juncture, I'd like to welcome upstage the co-chair of the Global Sponsor a Students Program, Dr. Olabisi Oshikanlu, to give us the GSAP update. Please give her a round of applause, please. Yeah. Continue the applause till she gets here. Thank you.
Professor Temidayo Gundiran, ably represented by Professor Olaleye. Emeritus Professor Omakodion, my teacher. Good morning, thank you, sir. Also, I'd like to recognize Professor Adeshino, Olubukala Adeshino, who is wearing many hats today, representing the CMD and also the Global Sponsor Student Program. Imsg Ibadan Medical Specialists Group, welcome home and thank you so much. Dr. Bode Williams. When GSAP was born, the idea came up with Professor Olayinka Omigbodu. It wasn't just for charity. It was born out of a conviction that every student has a right to education and that no student should drop out of school or out of college for financial reasons. And thankfully, the current provost and his administration, Professor Temidayo Gundiran, have continued this legacy. They've continued to enable us. Our work at GSAP is guided by the ACEIT framework, ACEIT, creating awareness, continuity, empowering our students. So we're not just giving money, we're also mentoring the students. And a couple of months ago, Professor Olaleye had a town hall for the students on research protocols and studying research. And it was really wonderful. It was one of our most attended, yes, town halls. And then the IT is inspiring trust and transparency. Again, this morning when we met with the students, Professor Adeshino mentioned that people are very suspicious when you ask them to give money. And so at GSAP, we're very transparent about people's money. Every single dollar, pound, euro, naira is accounted for. I'm just going to run very quickly through what IMSG has done for us. Since 2021, you have stood tall as champions of hope. Through your generosity, the Global Sponsor Student Program has received 10.6 million naira and 9,794 pounds supporting, yes, thank you, supporting 24 medical students. Of these, 13 have graduated, now serving with distinction across Nigeria and beyond. One passed her medical board examinations, the second MB, with distinction in anatomy. Victoria Legbede, if you're in the room, please stand up. Is she here? Is Victoria here? I saw her this morning. So that shows you that what we're doing works and what IMSG is doing works. A beacon of excellence has been made possible by your kindness. 10 scholars remain under your sponsorship, continuing their journey in medicine because of your steady hand and open heart. And this year, as you mentioned, Dr. Williams, you climbed Mount Kilimanjaro. I don't know if I can even climb the stairs sometimes, but you raised the limits. You rose above the limits to raise awareness for the Global Sponsor Student Program. You also contributed £5,000 in 2024, and again this year, you doubled your impact. IMSG continues to prove that impact is not an event, it's a culture. And you've done this for 30 years, 3 decades, and we're appreciative. So what's the journey ahead for the Global Sponsor Student Program? We are not standing still. We are moving forward. We're strengthening our structure and expanding our reach to ensure that every act of generosity creates ripples that last generations. Here's what's next. We're launching, okay, this is our logo. This is the first time we're showing our logo. So we're launching our logo, the Global Sponsor Student logo, nestled between the College of Medicine, University of Ibadan logo and the Ibadan College of Medicine Alumni Association logo. And as Dr. Williams mentioned, no man is an island. We can't do this work alone. It takes collaboration, and that's what we're gonna do. We're getting ready to launch a website with a donor platform for real-time impact tracking. We're expanding our donor base, inviting alumni, year sets, and corporate partners to join this movement of hope. We continue to host town halls every other month to foster mentorship, well-being, and a sense of community. We're also publishing quarterly impact reports to maintain full transparency and celebrate every milestone with you. And for those moved to continue their support, donation details will be shared. If you could move on to the next slide and show the donor details, ways to donate. And so in a short while, after Professor Adeshina's address, we will present IMSG a plaque of honor, a humble token of our deep gratitude for all you have done and continue to do. IMSG, you have lit a torch that continues to burn brightly. You have proven that when purpose meets passion, progress becomes power. When you lift one student, you raise a family. And like I like to say, you have been a river, not a reservoir. When you educate a generation, you transform a nation. Your impact is not just a moment, it's a movement. Your generosity is not just a gesture, it is a legacy. We don't just appreciate you, we celebrate you, because when hearts align, legacies shine. I would like all the Global Sponsor Students Program scholars to rise to your feet and just say a big, big thank you and a round of applause to the Ibadan Medical Specialists Group. Thank you so much. Thank you for giving us this opportunity. Thank you for giving us this time in your packed program. We appreciate you, we love you, we celebrate you, and we honor you.
Thank you so much. So very quickly, I want to welcome, I want to invite the president of IMSG to please come, and members of the IMSG come up stage to receive your award, which is being presented by the GSAP, Global Sponsor Students Program. The secretary, Dr. Adebayo, please come. Yes, please come up stage. I'm going to present. It's a joint prize. Okay, let me hand this over to you. Yeah, out.
Good morning, everyone, again. With great joy and appreciation and gratitude, all our students on the IMSG sponsorship, every student of the College of Medicine, University of Ibadan, faculty, and the board of the Global Sponsor a Student Program want to appreciate the Ibadan Medical Specialists Group. Today, this is just a token. There is nothing we can give that can measure up to what you have been doing for us. And we just want to present this token to you this morning.
Ibadan Medical Specialists Group in recognition of your generous support and unwavering commitment to the students of the College of Medicine, University of Ibadan, Nigeria. Your dedication empowers the next generation of healthcare leaders. With heartfelt gratitude from the Global Sponsored Student Program Board of Directors. Thank you so much.
I would like to express my sincere gratitude to Dr. Shikalu, Professor Deshino, Dr. Falabi, and the entire GSAS board for their exemplary leadership and for always providing timely academic progress reports on the sponsored students' achievements. Like I alluded to before, it's always uplifting to receive those joyful news and letters from the students about how the scholarships are impacting on their progress and achievements. So we thank you for all that you're doing. Thank you so much. Yeah.
Thank you very much, IMSG. Thank you, GSAP, Global Sponsor Students Program. So, very quickly, we move into the symposium proper. And the sub-theme for the first aspect of the symposium is trauma management. And it's my pleasure to welcome upstage to share the UCH experience. Dr. Kehinde Ojifini, a specialist emergency medicine physician. Please, let's give her a round of applause. Him, rather, a round of applause. Thank you.
Good morning, everyone. Because of time, I'm going to stand on the existing protocol, but permit me to still appreciate the host, as the provost of the college, and special guest, the CMD of UCH, and the president of ICOMA, sir. You're welcome. And also the president of IMSG, and my very good friend and brother, Dejo. Thank you very much. And to the host of others, my senior colleagues here present, my colleagues and medical students, you're all welcome. This morning, in the next few minutes, I want to try and convince you to become emergency physicians. Right, if I can do that in 10 minutes, I hope I can. So I'll be talking about emergency medicine, the UCH experience. My name is Kehinde Ojifini, and I'm a consultant emergency physician. I work here at the edge of chaos in UCH. Right, this is what Ibadan is known for. Ibadan is known to be the home of many firsts. You know, I would say the first TV station, the first radio station, the first skyscraper, and also in the academics, we are not left behind. It's the first, foremost, the best university, the best teaching hospital, all the first things are in Ibadan. And I must sincerely appreciate the Imsg-Uk for making us talk about emergency medicine this time around, because also there are many firsts in emergency medicine in Nigeria, and all those firsts are from Ibadan. So the primary examinations for the first time held in October 2021, and some of doctors who were medical officers already in the emergency department sat for that exam, challenged the exam, and passed. And then we had the first set of doctors who had primaries in emergency medicine for proper training in emergency medicine in 2021. And then the accreditation program, the first of its kind, which was done by the National Postgraduate College, the Faculty of Emergency Medicine, also happened first in Ibadan, UCH Ibadan, in 2022. Everybody was given partial accreditation so as to see if you will be able to sustain the tempo or whatever is expected of you. And we did well. And 2 years after, in 2024, precisely December, we were awarded a full accreditation. Thank you. As I speak, University College Hospital Ibadan is the only training institution for emergency medicine with full accreditation. So emergency medicine residency training started in earnest in 2022 because we had many medical officers who at that time had their primaries in emergency medicine. I must say that just last week, we had the first set of residents who challenged the Part 1 examination in the Faculty of Emergency Medicine of the National Postgraduate Medical College. We had 4 of them that left from Ibadan to go to Lagos for that exam, and we had 100% pass. Some of them are here already. I can see about 2 or 3 of them, but in the afternoon section, you're going to see them demonstrate some skills of emergency medicine to you. Like I said, in 10 minutes, I want to see if I can convince you to become emergency physicians. Sorry, man. All right, so there are senior registrars. The first senior registrars in emergency medicine in Nigeria are here. All right, this is where we are. This is UCH, about 1,000 bedded. And that part where you have there, it's where you have inpatient area, the southwest, northwest, southeast, west-west, east wing, and west wing. And then where you are, that blue one is where we have the outpatient department. And it's been extended now. I hope emergency medicine can still get some more areas in the outpatient department as well. Okay, and that red part is the emergency department. That's where I work. And it's 32 bedded, even though we can see more than 40, 50, 60, 70 patients because we just have to move per time. All trauma, whether adult or pediatrics. We don't see pediatric non-trauma patients, and we see OBGYNs after hours. So College of Medicine is this area where we are. It's on the west side of the complex, and it's Hendrickse. Okay, so the emergency department complex itself, which some of you might have known, and for some of our older colleagues who have not been around for a while, there's been a lot of change from what we used to know as casualty in those days to what we now have as emergency medicine department. We'll talk about that shortly. So this is what it looks like. So now we have what we call the short stay ward. Okay, you come in through that end, and then you are in the triage section. POCT there stands for the point of care testing room. You'll see that later on in a video I will show you shortly. Because we in emergency medicine encourage the doctors to do their bedside investigation, such that the ultrasound, the use of arterial blood gas machines, and some other things which we'll talk about shortly. And then we have a 3-bedded general resuscitation room and another 2-bedded trauma resource with the equipment to go. We have a short stay of about 18 beds, the doctor call room. All those ones in red are the critical areas. So in the complex, there is an emergency department theater, is 2 suites. We have the burn ICU, the plastering room where you have patients who might need a close reduction, and there are offices. Radiology department has a unit in the emergency department with CT scan, X-ray, and ultrasound. Right, so our journey from casualty to emergency medicine department, what's in the name? So it's important to remember how we started like a casualty unit, then on the southeast ground, which is currently the Otumba 2HA Children Emergency Ward. That was very many years ago, maybe before someone like me was born. And then later on, we moved to the current site now as the casualty unit under the Department of Surgery. And when the need for more specialized care came up, and there is need for to incorporate all other departments and units into it, 4 medical officers were appointed in 2002 to 2003, and at that time they still reported to the head of the orthopedic and trauma. And after that, we evolved into a full department in 2003, and the very first head of departments was the then doctor, who is now a professor, Dolapo Afuakwe. The name evolved from casualty to accident and emergency, and then following what the trend is now, is called emergency department. And because it's a training department now, it's a department of emergency medicine. Right, so what's emergency medicine? So you can say it's a medical specialty that focuses on the immediate recognition, evaluation, stabilization, care, and disposition of patients of all ages and with acute illnesses and injuries. Like I tell people, anything that walks through the door, you fix it. Right? Some have said that we are the most interesting first 15 minutes of any specialty. So if you like to be jack of all trade and master of all, you're welcome. If you like to be on steroids, drugs, you're welcome. All right? And if you like to work at the edge of chaos, we inject some adrenaline into you and you can do the job. Right? So we actually go into immediate care of patients. If you don't have very long attention span, you're welcome. Just take care of your patient, saw the patient, and move to the next one. A lot of our patients are undifferentiated. So just like what Professor Lagunju will tell you about pediatrics, they can't tell you they have a headache or something. So there's a lot that has to be done. You must have your clinical acumen and some armamentarium of toys around you that you use to actually decide that a patient who comes before you unconscious, this is the very cause of that unconsciousness. And you see that in the afternoon when we do the role play for you. The scope of practice is broad, and we also use a systemic approach or systematic approach to patient care. And time is critical in emergency. You're dealing with a patient with acute coronary syndrome, you say time is muscle. If you're dealing with a patient with pulmonary embolism, you say time is air. If you're dealing with a patient with acute ischemic stroke, you say time is brain. If you're dealing with a patient who has collapsed and you're doing his cardiac arrest, you say time is life. And if you are dealing with a patient who is polytrauma with traumatic hemorrhage, time is blood. All right, so everything is timely and is critical. I hope I'm getting your interest, eh? Okay, so the skill set that we expect from an emergency physician is also the skill set you expect across board. Across board. And this skill set includes your cognitive skills. In emergency medicine, you must know a lot of things. You must read around so many things. And we use kind of type 1 and type 2 reasoning and a lot of algorithms so that you can work on the spot. Right? You must also be hands-on, because emergency medicine, you need your hands. So your psychomotor skills. And lastly, your affective skills. You must have a heart for what you're doing. You must have a heart for the job. All right. We are a product of what we eat. This is what we feed our residents with, and that's what we're going to feed you with as medical students when you come to us. We do this BBC combo, bread, butter, and coffee. So these are acronyms for how we do our academic meetings. Yes. So you're welcome to come feed with us. So BREAD stands for Breakfast Emergency Academic Drills. You can ask the resident, they'll tell you after every ward round, especially on Mondays, Wednesdays, and Fridays, we have like a 30 minutes of just 30 minutes of drill. So we just pick someone randomly and say, you have a patient to present with this, tell us how you're going to manage, and we all critique what the person says. And sometimes we have well-structured simulations as well as our bread. Butter is better understanding by teaching and training in ECG and emergency radiology. And that's a place where we look at ECGs, we look at CT scans, we look at X-rays, and what we can make out of them. And coffee stands for clinically oriented fact-finding evidences in emergency care. And that includes our journal club. That includes the coffee brewers. We have the people who call coffee brewers, and that's the residents who are interested in writing. And I've had some medical officers who have published papers from the emergency department. A round of applause for them. Oh yes, they came to us and they said they are interested. And some of them even attended the Ghana conference, the AFSEM conference in Ghana in 2022. And they did have some presentation. You have challenges? Yes, we do. And these are the challenges that we face on a daily basis. Healthcare financing, because emergency does not advertise. It doesn't give you a time when it's going to happen. And then people don't keep money for emergency. We hope very soon we'll get to a level where we can have a kind of managed healthcare that can take care of emergencies. Incessant industrial actions. One is ongoing now. We have a lot of problems with pre-hospital care because of lack of ambulance services. Our referral systems aren't great, so a patient just shows up at the door without you knowing ahead of time what the patient is coming with. But we're trying to douse that by having an emergency number that can be called, and through that emergency number, people can tell that the patient is coming, and they can tell us the expected time of arrival. The flow, like everywhere in the world, we're having issues with access block, exit block, and overcrowding. And of course, we are at the front door, so there's a lot of litigation. All right, you're aware of this one. It's very common. And we're trying to see how we can mitigate that as well. What about the undergraduate? Is there anything for you? Yes. There was a publication by a student, 2021, who happens to be a member of the Emergency Medicine Information Interest Group. And that talks about emergency medicine as a career, knowledge, attitude, and predictors in Nigerian medical schools. And the outcome of that study shows that the level of knowledge about emergency medicine resident training is low among students, and that almost all the respondents in that study felt that emergency medicine training should be established. That was in 2021. So now we are 4 years into the emergency medicine program. So this will have changed. All right, for the students, we are thinking that should be a time where we'll be having didactic lectures on certain topics in emergency medicine that will be applicable to you as students. You are welcome to do your rotations in the emergency department and also electives. Some have been coming for electives. Want to appreciate Professor Olagunju for the skills lab simulation and also the whole of the College of Medicine. Please make use of the skills labs for simulation. The Emergency Medicine Interest Group did a boot camp 2 years ago at that place, and it was well attended. All right, more collaborations are needed. We're still getting some collaborations, and we know we'll still have more. Just listen to this for a few minutes, and then we'll round up. The technical team.
Yet highly organized department. Because of the peculiarity of attending to truly emergency cases, not all patients that present here are ultimately admitted. But once you've been passed by the attending doctors at the trolleying area, you're officially received at the dropping off zone. Here, the patient is moved onto a trolley or wheelchair as the case may be. They are carefully moved into the section of the department that best suits their case, to the resuscitation room if they need very urgent medical and nursing care, and close monitoring, of course on arrival or any time at all during their stay. Accurate, yet timely decision making is of utmost importance in the management of patients in the emergency department. And so we rely very much on high-tech point-of-care services such as arterial blood gas evaluation and bedside ultrasound. These services yield instant results to foster precise and excellent management of our patients. Needless to say, is how we thrive on excellent teamwork in the emergency department, with consultants, principal medical officers, and rotating residents working hand in hand to ensure the delivery of high-class health care within the department. And well, if it is not bedside, it should be close by. And so the digital X-ray unit is found right at the center of the department to make access very easy. After the initial urgent care given to all of our patients, they are eventually moved to the short stay ward for further observation and or further care by invited specialist teams. And oh yes, we can be very busy saving lives. We sometimes find time to celebrate our patients. Nice, right? It's amazing how we see that lift their spirit tremendously. And so I would say that we give all-round care here. Some patients don't need a trolley or a wheelchair and still need some form of urgent care. Any patient that is deemed to be in this category after appropriate questioning, what we call triaging, is put in the vertical triage section. This section also doubles as the waiting area for patient relatives. In case you've heard about the PUI section, it is a part of the emergency department. It's designed for patients under investigation for a pandemic or a highly infectious disease. It affords us the opportunity, giving top-notch care to the patient in question, while also observing important protocols for safety for both the attending healthcare professionals and other patients. And then to this special group of professionals, nurses in the emergency department. Empathetic, observant, and hardworking group of people, especially as it relates to patient care. And hey, we find time to learn too. We can't afford to not keep abreast of the latest inventions and lines of care for patients in the emergency department. We have certified and dedicated emergency consultants that take us through regular periods of teachings, didactic learning, either in form of practical sessions or even hands-on. In this department, even our walls speak. Just a glance at the walls will give you good information about the management of important presentations to the emergency department. And so I would say again that we're really deliberate about improving ourselves every day. In addition, we have weekly academic meetings that feed us with the continuous medical education that is needed for ceaseless seasoned training in emergency medicine. We are deliberate about creating smooth working relationships and the delivery of top-notch emergency care. Emergency Department, University College Hospital, Ibadan. The eye of the hospital, an amazing place to be.
Thank you. No, we are not giants. We are just standing on the shoulder of giants, and that's why we're like tall. There have been previous heads of departments of emergency. We want to appreciate them all, and also we want to appreciate all the past and present provosts, CMDs, and CMACs. Thank you very much for your attention.
Let's give him a round of applause. I asked him that the patient that we saw online, that they presented this cake, that we saw the face, he said permission was duly sought. So that should be noted. So they took permission for filming. Everybody that appeared in the picture had their permissions taken. Let's give him a round of applause, please. Very quickly, before I welcome the next speaker, the Ibadan College of Medicine Alumni Association has 2 awards to give to the co-chairs of the sponsor, the student program. And this will be anchored by the president of the Ibadan College of Medicine Alumni Association Worldwide, Emeritus Professor Samuel Omokojo. Please, let's give him a round of applause. I'd like to welcome upstage Dr. Bisi Oshikolu and Dr. Bosse Adebayo to receive the awards on behalf of Dr. Adeshina and Dr. Oshikolu. Thank you very much.
I really do crave the indulgence of Imsg-Uk to sandwich this particular aspect of the events in between the rest of this, because this was meant to have been done next week during the ICOMA homecoming week. However, Dr. Oshikolu has come all the way from the United States at her own expense. This is not a matter of taking a bit of what is collected for travel expenses. I sit at the office, and I can assure you there's a very stringent scrutiny of all that comes in by way of donation. And I assure you that there is no administrative charge deducted, even for administering this fund. Now, when this program was birthed, there was a careful selection of the co-chair. Now I see why the provost at the time went to great lengths to convince us that these will be the best for inception of this program. Mothers, they both are. Passionate, they both are. Full of empathy, they both have it. And they go to great lengths. Now, if you've ever had the opportunity to come at the receiving end of Dr. Oshinkolu's appeal, there's no way you will say no by the time she is done with you. She is excellent at the job, and she does this so well with the co-chair. And there were a few things I didn't even know about the General Secretary, even though she was in my unit before I retired. I want to think that both of them have already started a process of infusion into the General Secretary. And ladies and gentlemen, this is the President's Special Award to outstanding workers that are executing and overseeing the execution of special ICOMA projects. It can be awarded to class sets, can be awarded to individuals, it can be awarded to group of persons. The other recipients will be kept under wraps until next week. But because the two persons who are receiving today's award, like I said, should have been next week, they're traveling back. This is why we have brought this forward. You will agree with me, Dr. Bisi Oshinkolu deserves in every sense this listening. They got a whole church to buy into this program and donate laptops to students. I have a record of all that comes in the ICOMA office. So I speak from the vantage position of knowledge. So this does not pay you back. This says to you, we see what you're doing. This says to you, what you're doing is appreciated. You're leaving a legacy. And when the beneficiaries of this program were earlier requested to stand up, almost the entire hall were standing. God Himself will reward you. And God Himself will reward the co-chair along with you. We're not saying this is in any way a payment. We simply want to, and we do appreciate very much the efforts the personal sacrifices, and all you do to ensure that this program is a reality. Let me ask the other half to please come forward and join your wife in the receipt. Because when she travels out of the home, unless you agree, she may not be able to fulfill. So we recognize the fact that you have given a lot of support in this endeavor. And you pray for her. You miss her at home when she goes out. We recognize all of that. And we thank you for the invaluable support that you provide that enables her to carry this out. So this goes not just to her, but to both of you. Congratulations. Yes, you will.
First of all, this has come as a complete surprise, but I just want to say a very, very big thank you to you, sir, and to Dr. Bajimi, who is Vice President of ICOMA Worldwide, and also a part of the board of the Global Sponsor Student Program. I really want to dedicate this plaque very quickly to my mother, and I'm going to cry. Mrs. Cecilia Oshikonlu. My father passed away in 1971, and my mother, who is from Grenada, West Indies, raised 5 children on her own right here in Nigeria. And so I dedicate this to her and to all the scholars. I know your struggle. It is well with you. You're going to be okay. Thank you so much, sir. I really
Congratulations. Of course, the co-chair is also the recipient, but I have been informed she has had to go represent the chief medical director at another event. And so she has asked the general secretary to receive this on her behalf. And I want to say to you, everything I have said about Dr. P.C. Oshikonlu is also true of Professor Bukola Adesina. And both of them, this is not full-time job. They have their respective full-time jobs. And they have their families to look after. And yet, they have struck such a work-life balance to enable them to go all the areas, make trips, soliciting support for this program from one place to the other, state to state. And I want to truly extend the appreciation of not just the executive committee of ICOMA, but also the management of the college, that you have done this job excellently well. And I repeat, they make no administrative charges. All the trips they make at their own personal expenses. And they have gone, they have spared no effort to ensure that this program runs well. So I make this award to be received on behalf of Professor Adesina by Dr. Bose Adebayo, the General Secretary of Global Sponsor Students Program. Do you want to make any response on her behalf? Did she instruct you to? No. But do you want to?
On behalf of Professor Olubukola Adesina, co-chair of the Global Sponsor Student Program. I would like to say a big thank you to ICOMA, our daddy, our teacher, the team, Emeritus Professor Mokodion, Dr. Bolan Obajimi, Professor Adanze Asinobi, Dr. Shitu also present. We want to say a big thank you for the recognition of the sacrifice of my chair and my co-chair to this program. Thank you, sir.
Thank you. And I thank Imsg-Uk for allowing us to sandwich this in between the program. Thank you very much.
Thank you very much, sir. Let's give him a round of applause. Our next speaker is no one else than our teacher, our amiable professor of pediatrics, Professor Ikeoluwa Lagunju. Please give her a round of applause. She was my teacher, so please continue. She'll be talking to us about basic life support, and I'll just hand over the mic to her to do justice to that. Thank you, ma'am.
Thank you very much, Dr. Bajimi. The Provost of the College of Medicine, the Chief Medical Director, UCH, the President, ICOMA Worldwide, our revered teacher, Emeritus Professor Esa Omokodion, IMSG President, IMSG Education and Research Secretary, yes, I got it right, and distinguished guest speakers, students, and everyone here. I want to thank the IMSG for giving me this opportunity to talk about basic life support. Let me remember to recognize my teacher, Professor Adanze Asinobi. Thank you, ma. So I'll be talking about BLS. It's a whole day course. Sometimes it takes more than a day. And then IMSG is asked me to come and talk about it in 15 minutes. So that's an Herculean task, but I'll do my best. So in the course of this, I'll talk about what BLS is, why BLS, and then the life-saving steps in BLS, and what our experience has been with teaching BLS in the College of Medicine. So BLS is basic life support, and it's the foundation for saving lives after a cardiac arrest. And when we talk about BLS, it has two major components: cardiopulmonary resuscitation and relief of foreign body airway obstruction. And with BLS, BLS refers to the types of care that first responders, healthcare providers, and public safety personnel provide to anyone who is experiencing cardiac arrest, severe respiratory distress, or an obstructed airway. So you see that, it spans through whoever is there when it happens is the first responder and should do something. And BLS has evolved over centuries, and it can be traced back to as far back as the literary works of ancient Egypt, and it's evolved from using primitive methods to modern day cardiopulmonary resuscitation. And when you actually read the story, you wonder what went through their minds. At some point, some people use the bellows fire works, and they tried to put in air into the lungs, and then at some point, or in the 1800s, and they did that for about 300 years, and then somebody got up in 1800, no, let's just simply turn them on their side, and they'll be fine. And then later, between 1900s and the 1940s, it was like, okay, then the dogs, when we compressed the chest, it actually brought back the heart, and so, but not until 1960, that something in the direction of what we know today came to be. And again in that 1960, the Resuscitation, which was a life-size CPR training mannequin, was made. And in the since then, up till now, we've had more than 400 million people trained on BLS and still counting. So, talking about CPR, I did say that earlier, a series of life-saving actions that improve the chances of survival following cardiac arrest. And indeed, it's a critical emergency procedure. This is, a series of actions that are offered to sustain blood circulation and oxygen delivery to essential organs until normal heart functioning can be restored. And let's look briefly at what happens during a cardiac arrest. The heart stops abruptly with little or no warning, and this can happen within the hospital or out of the hospital. And once the heart's pumping action is disrupted, then blood supply to the brain, the heart, and other vital organs become compromised. And within seconds, everything goes awry, loss of consciousness, cessation of breathing, or the victim begins to gasp. And without early and effective CPR, the patient dies. So CPR can help to keep the heart pumping and blood flowing to vital organs until an electrical shock from a defibrillator becomes available to restore the heart to normal rhythm. That's on the background of the fact that the cardiac arrest usually occurs as a result of some aberration in the cardiac rhythm, and the patient can then be safely moved for the treatment. So when we talk about BLS or we talk about CPR, there's what we call the chain of survival. And the strength of any chain is as strong as its weakest link. So you imagine that every part of this chain is crucial. You have, and it starts with early recognition, activation of the emergency medical service, early CPR, rapid defibrillation, access to advanced cardiac care, and then the post-cardiac arrest care. And lastly, the recovery when the victim has regained life consciousness and then needs to get bonded and reintegrated into the society. And the series of actions that link the victim of cardiac arrest with survival is the chain of survival. And a strong link can improve the chances of survival and optimal neurological outcomes, because you don't just want the victim to survive, you want the neurological outcome to be splendid following a cardiac arrest. So how do I then know if a victim has suffered a cardiac arrest? Two major things: sudden loss of responsiveness, no movement, no reaction to calls, no response, and then absence of normal breathing, which could be no breathing at all or gasp. And once this is recognized, the way you can help that individual is to activate the emergency medical service. And for the the steps involved in cardiopulmonary resuscitation, the primary thing is to ensure scene safety, because people have talked about trying to help other people and then they got run over by other vehicles in an accident. So ensure scene safety, protect yourself, and the next thing, assess responsiveness. How do you do that? You tap the shoulder, you shout, "Are you all right? Can you hear me?" And then when there's no movement, no response, you know the individual is unresponsive. And the second sign, or the second indication, or the criterion, the victim is unresponsive. Is this person breathing? And is this person breathing normally? And if these two are no, the victim is unresponsive, not breathing normally, you need to activate the emergency response team and ask to get the AED, and you start CPR immediately. And it's no longer ABC. It's only the neonatologists who talk about ABC now. It's been CAB for more than a decade. And in all adults, children, and infants, you must start with chest compressions. And the emphasis is on high-quality chest compressions, because evidence has shown that this is indeed a game changer with resuscitation. And so what are the criteria that define high-quality chest compressions? You must start the chest compressions within 10 seconds of the cardiac arrest. You push hard and you push fast. When you push hard, you depress the chest about 1/3 of the AP diameter. So for the adult, at least 2 inches or 5 centimeters deep, and you aim for a rate of 100 to 120 per minute. You minimize interruptions in between compressions, and then you take your weight off the victim to allow full elastic recoil in between compressions, and you avoid excessive ventilation. So that's C, and then you go to A. You need to open the airway. How do you open the airway? This will be done in the afternoon at the hands-on session. It's the head tilt, chin lift maneuver. But if the individual has been through trauma, that will be unsafe, and so you have to use the jaw thrust. And when the airway is open, you go to the B, and that's the rescue breathing. And out of the hospital, you use a pocket mask, but in hospital, you can use the back valve mask device, and you aim to deliver the breath slowly over a second, and you give a rescue breath every 5 to 6 seconds, so that the target is 10 to 12 breaths per minute. And when you deliver the breath, you need to ensure that the chest rises. If the chest does not rise, then the airway is not patent. And so you have to go back to A to open the airway, and you allow, after delivering the rescue breaths, you allow exhalation, and usually you combine this, the C, the A, and the B. So for 30 compressions, you give 2 rescue breaths. And this is just to show how to hold the mask. We'll talk about this better in the afternoon. And it's important to say at this point that for the CPR, there are age considerations. So the adult, an adult is somebody who has the secondary sexual characteristics, you know, the signs of puberty. For a child, it's never a time to ask how old you are. So for the child, you define a child as an individual who doesn't have any signs of puberty. So for the female, breast buds, and for the male, axillary hair. And for the infant, that's pretty easy, the first, anyone under the age of 1. And the pediatric, just as we have the adult chain of survival, we have the pediatric chain of survival. And the point I like to make here is that rather than the early recognition and immediate activation of the EMS that you have for the adult chain of survival, the first link here is prevention, because a lot of the cardiac arrest in young children in the pediatric age group result from asphyxia and from, you know, different things, diarrhea, pneumonia, shock, sepsis, and not from intrinsic heart disease. And this is just to show that the way the chest compression is offered in infants is different from what you have in adults and in children. So that's the 2-finger technique if it's a lone rescuer, and then you have the hand encircling technique if you have somebody helping with the airway and all you're doing is with the compressions. And for the child, you use the heel of one hand, particularly if the child is not big. There are 5 common CPR mistakes to avoid, and I think it will be important that I leave this with you. Rescue exhaustion. I mean, it's serious business offering chest compressions. And if you don't, if you keep at it and you don't get somebody to support you, then the risk is that the rescuer gets fatigued and compressions become ineffective. So it's recommended that you change after every 5 cycles of 30 compressions to 2 breaths, and that usually will take you to about 2 minutes. And then leaning on the victim in between compressions is another pitfall that we should avoid, because it would not allow for full elastic recall of the chest, and then mistiming chest compressions around AED shocks. The AEDs usually, they are automated and they tell you, everybody clear, stop compressions. If you're not listening, you might get some shock. And then people still, you know, keep checking for the pulse. No. Check for responsiveness, check for respiration, breathing, and then it's advocated that you don't wait further time, particularly when this is a non-healthcare provider rescue, and then the long overemphasis on rescue breaths. Chest compressions are very important. And then foreign body airway obstruction, very quickly. This is quite common, and this occurs when a small item gets stuck in the throat or the upper airway, making it hard for the victim to breathe. And 80% of the cases are children less than 3 years, and majority, about 65%, you find in infants. And why do you worry about foreign body airway obstruction? Gaseous exchange, oxygen exchange becomes compromised, and then the child rapidly, lapses into unconsciousness. And if it's the airway, obstruction is not relieved, it can lead to death. So there's a high risk of death without prompt intervention. How do I recognize an infant who is choking? The infant becomes unable to speak or vocalize. The cry is very weak or absent. The child is unable to breathe or has severe difficulty with breathing. There might be wheezes, cough is absent. The child may turn blue, and then consciousness diminishes. And for the child and the adults, you have the universal choking sign. And when you ask, are you choking? And the person says yes, is the person choking? All right, okay. And then so for the adult And for adults and children, use the Heimlich maneuver, and we'll talk about that in more. But that's just to show you, for the child, because of the size of the child, you may have to kneel behind the child to help the child. You wrap your your arms around the tummy and about the level of the belly button. And for the infant, it's a different kind of maneuver. You rely on back slaps and chest thrusts. And if a victim of the foreign body airway becomes unresponsive, then you must begin CPR. So what has it been like in the College of Medicine, University of Ibadan? ComUI became an accredited international training center of the American Heart Association in 2006. And this was facilitated by ACOMA North America. We had some itches. Yes, I think you should appreciate them. Thank you. And then the status, we had some itches, and then our status got reinstated in 2013, and that was when I had the privilege of being asked to lead the team and be the coordinator of the training center. And this is just to show you what we were able to do between 2013 and 2020. When COVID came, we trained an average of 500 people on BLS every year. And over the 8-year period, we had a total of 3,967 people trained. I thought you would clap. So, like 500 every year. And I think it did make a lot of, and who were these people? These were medical students as soon as they crossed over from UI to UCH at 300 level after the Part 1 MB. And then we had nursing students as well as physiotherapy students. And then also UCH had a policy, you couldn't start residency, and the nurses couldn't start, new nurses, new hires who were nurses and doctors couldn't start their job without being certified. And at that time, we had the AHA certification and we could. But unfortunately, when COVID came, it just threw everything apart, and we're trying to recover. And what we do now, I know in pediatrics, at the end of the junior posting, our students still get taken to the skills lab, and they're taught the technique of BLS. So as I wrap this up, I would like to say that the most important determinants of his survival of any victim of sudden cardiac arrest is a trained rescuer who is ready, willing, well-trained, and able to act. And BLS is a large sequence of actions, and it is likely that the combination of the actions, each performed correctly in time and in order, that will lead to that optimal survival. BLS skills require hands-on training and certification, and I hope you would now eagerly look forward to getting that. And so I'd like to acknowledge IMSG, ably led by the president. I'd like to acknowledge my friends, my classmates. I hope you can see the provost. Can you see the provost there? Oh, no. The only people who can't see the provost are the IMSG members, It's the students must see the provost. They don't have a choice. So that's our provost. And then you can see the person in between the provost and the commencement lecturer. So that's the commencement lecturer, Dr. Abel Adegoke. He gave the commencement lecture for the convocations yesterday. Thank you very much. And then that's Banji. Banji he served as Education and Research Secretary of IMSG. He's the immediate past president of IMSG, and he's been our class chair for several decades. And I'd like to recognize all the members of the class of 88. We have the director of the UI Health Services, Dr. Runke Ajab, Dr. Rola Adediron, senior lecturer in the College of Medicine, Dr. Sholakwe Adeboye. You are hiding there. Thank you, Sholakwe. So that brings me to the end of the lecture, and thank you, everyone. Thank you very much.
It's my pleasure to introduce the next speaker, Dr. Kayode Adeboye, consultant, emergency medicine physician in the United Kingdom. Please let's give him a round of applause. And he'll be presenting to us on ATLS. I think that is Advanced Trauma Life-Saving Skill. Thank you, sir.
Good afternoon. I've got 15 minutes to compress a 3-day lecture. So I'll be fairly quick about it. So yesterday I was also on the Lagos-Ibadan Express Road, and I simply watched people sat on all sorts of funny things, and there was no concept of safety. I saw people on trucks sitting on well-packed goods, where the truck can stop suddenly and you can fall off. And there was just no concept of safety. So my focus will be on advanced trauma life support. And I just want to talk about the various steps. The other thing I noticed is the lack of pre-hospital care in our country, okay? Because what you want to do is to manage trauma as quickly as possible to improve survival. So there has to be some pre-hospital element to the work, and then within the hospital, you have the phase where you receive the patient, that is in the emergency room, and then supported by other specialty like anesthesia, surgery, orthopedics within the same hospital. So at the point of injuries, commonly falls, road traffic accident, assaults, you need the good pre-hospital care, emergency services with good responders who have the basic skills to do the initial management. And then obviously followed by transport to the hospital, and then, like I said, the reception team, where you may have a trauma call. In the UK, certain things will make you activate a trauma call, which will bring a group of specialists together to receive the patients. Then you have the definitive care, which is the hospital care, which involves specialists, like I said, orthopedics, anesthesia, and the various other specialties. So advanced trauma life support is split into 2 main stages. You have the primary survey and the secondary survey. Identifying life-threatening stuff. You want to identify these things and manage them, treat them immediately. Okay? And the general concept of the primary survey is what is called C, the big C, the small c, and then the ABCD approach. Okay? The big C is catastrophic bleed. And that's we need to focus on nowadays. It's not just the small c, which is cervical spine management. What kills a lot of people is the poor management of bleeding. People are bleeding, obviously, and you need to do something to stem the bleeding. You need to stop it in various ways. And we'll get to that. So the small c is cervical spine control. I was describing to you these people sitting on these various trucks who could be thrown off. And if they landed on their heads, obviously there's a high potential they may injure their cervical spine, leading to paralysis forever. Okay? Then you've got A, which is the airway management, the B, which is the breathing and management of the chest, C, which is management of the heart, disability, and exposure. So, talking about catastrophic bleed, there are 2 types of bleed. So, whether it's visible or non-visible. So, the visible ones are often arms, legs, things you can see, torso, and you need to apply some form of compression to stop it bleeding. Your invisible ones are internal injuries. You won't see them, but you can assume the potential for internal bleeds. And your patients would also give you some indication they have internal bleed. So you see a huge bruise to the torso, a huge bruise to the chest, deformity to the chest. The potential for having internal injuries to either chest or abdomen is very high. You cannot control that. You don't have direct access to control internal bleeding. So that's why you need some initial management, initial care of that patient till they get to the hospital where somebody can fix those problems. So in terms of managing this type of bleed, so if you have an external bleed, you can apply a tourniquet, but with caution. Any tourniquet you apply to, particularly in limbs, you must make sure that they do not stay on longer than just over an hour. Otherwise, they are going to kill that limb. So it just gives you enough time to get the person to hospital so that somebody can control the bleeding there. The simpler things is just to pack. Just put a lot of packing, particularly if it's a cavity and you can't see it. Just put a lot of pack into it and apply compression. That will give the bleeding some time to coagulate and control the bleeding. Within the hospital, what we tend to do when patients arrive is massive transfusion protocol, what we call a shock pack, which will provide you 2 packs immediately of all packed cells, FFP, and forgotten the third bit. We'll provide you those 3 immediately, and that you need to transfuse immediately. The other thing we use is tranexamic acid, particularly in patients who have had significant bleed. So you give that intravenously, and you can repeat that within another 10 minutes. So massive transfusion to help to optimize the patient's outcome, use of tranexamic acid, stop the bleeding by use of tourniquets and packing. Cervical spine control, like I said, if you get thrown off, blown up, thrown from a height, there is the potential for cervical spine injury. And because of time, I can't go into details about Canadian spine rules. So somebody who's been involved in some form of trauma, you can apply the Canadian C-spine rule, which will tell you whether this person requires cervical spine immobilization or not, or whether you can do without imaging, that is either CT scan of the neck or X-ray of the neck, depending on their age. So kindly look into that. So always consider the mechanism of injury. So if somebody has been thrown from a height, has been involved in a road traffic accident, the potential for cervical spine injury is quite high. Okay, so always consider that. With cervical spine potential for injury, you want to immobilize the neck till you can be certain that there's no cervical spine injury. So essentially what you use, the cervical collar is not so popular anymore. It's still used. And then the main things are sandbags to support the head and tape across the head and the chin to make sure that the cervical spine is not moving. You can also do inline mobilization of the cervical spine to reduce the potential for injuries to the neck. One of the reasons why cervical collars are slightly out of fashion is when you have somebody who's hypoxic and they're combative and throwing themselves about, applying a cervical collar to that kind of patient worsens the potential for cervical spine injury. And obviously in children, you also avoid them. So airway is a major killer. Airway obstruction is a major killer in trauma. So like my colleague already said about assessment of the airway, make sure that there are no secretions in the airway. Blood, particularly if somebody has a mangled face, you have secretions, especially blood dripping down into the back of the throat. You need to find a way to stop that happening. Within hospital, that's quite easy. You just need to put a tube down to stop that happening. But in the community, everything accessible to you is the positioning of the patient to stop things dripping down the throat, so rather it drips out of the throat. Okay? So you can use airway maneuvers to adjunct things like that to support that, to make sure that the airway is open and your patient can breathe. You need to manage the airway properly. Otherwise, it's a major killer for trauma patients. The use of adjuncts, that is nasopharyngeal, oropharyngeal airways, can also be used to get the tongue out of the way and used to open the airway so that the patient can breathe. All this will be supplemental oxygen or the use of back valve to give them additional oxygen. So breathing, you want to assess the breathing. So what is the effort of breathing? What is the efficacy and what is the effect? Has it altered are they hypoxic? Has it altered their sensorium? Things like that. The main thing, if the airway is open, is to give supplemental oxygen. So give them oxygen. Most trauma patients will require supplemental oxygen. The acronym there, ATOM-FC, those are the big 6 killers of chest injuries. Okay? So when you have airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, or cardiac contusion or cardiac tamponade, those are the 6 big killers in chest injuries. So you need to look out for these 6 when somebody has a chest injury and make sure that you manage them adequately. So in terms of circulation, your general assessment is what is their general appearance? Are they well perfused? Do they look pale? Do they look pink? Things like that. What is the effort to get blood around? What is the blood pressure doing? What is the pulse doing? I'm sure you're all familiar that when somebody bleeds and they lose volume, the initial response is to increase the heart rate. And slowly, if things are not repaired, if you don't fix that, the heart rate will start to plummet. The blood pressure will plummet. So you want to give supplemental fluid to make sure that you supplement the circulation. You want to give blood products as early as possible. Remember the triad of hypoxemia, because you don't have enough oxygen, you don't have enough hemoglobin to carry oxygen about. Metabolic acidosis, because again, you are lacking in oxygen, and then that leads to coagulopathy. They have coagulopathy. All this is based on lactic acid accumulating within the system, disrupting the coagulation system, leading to decrease in myocardial contractility, and of course, if you don't do something to interrupt this cycle, then it leads to death. So management of circulation problem is get IV access, get fluid into them, get blood products into them. I talked initially about non-compressible bleed. That is where you need damage control surgery. So you need somebody who understands the chest or who is able to get into the abdomen, who can do that fairly quickly to try to get control of bleeding where you cannot see the bleeding. Okay? So disability, this is your assessment of your Glasgow Coma score. The optimal Glasgow Coma score is 15. Make sure you check blood sugar, particularly in children. Okay? And then exposure. Try to maintain dignity, also conserve heat. I know the temperature here is quite high, but it will be amazing when you expose somebody and you're using fans, how they can become cold and lose heat. So always be mindful of that too. So we've talked mostly about the primary survey, which is identify life-threatening stuff and fix them quickly. Then the second part is the secondary survey. Your secondary survey, once you fix the life-threatening thing, then the secondary survey is a slow head-to-toe assessment of your patient. So feel around the head, feel around the airway, feel around the face, and manage the things you can find. This is the part where you want to do your imaging, so x-rays, CTs, and things like that. So it's a gentle walkthrough from the head all the way to the feet, identifying abnormalities, both physical and physiological, in that patient and then making plans to fix those things. I've put there silver trauma. Silver trauma essentially is trauma in the elderly. They are a different group of patients. Okay? You and I, or most of you, very young, have very good physiological reserves. With the older patient, their physiology is different. They are on all sorts of medications. They are anticoagulated, they are on blood pressure tablets, and so the physiological response to trauma is different. So elderly people have to be managed in a different way. So that's silver trauma. So I hope in 15 minutes I have been able to give you an overview of what you need to do in advanced trauma life support. Any questions?
Thank you so much. Please let's give him another round of applause. Yes, thank you. Our next speaker is Professor Olugbenga Akinbola, who will be talking to us about pediatric shock and septic shock. Please let's give him a round of applause. We're trying to load the slides, and come and load the slides. Apologies for the delay in connecting. So once again, let's welcome upstage Professor of Clinical Pediatrics, Tulane University, in New Orleans, Professor Olugbenga Akigbola. Let's give him a round of applause, please. And he's going to talk to us about pediatric hypovolemic shock and septic shock. Thank you. You're welcome, sir.
Good afternoon, everybody, ladies and gentlemen. First of all, thank you, the Imsg Group and the provost of the college. It's indeed a pleasure to be here. I just have 15 minutes to talk about pediatric shock. That's a lot. So what I'm going to do, the main objective here is early recognition and diagnosis of the different types of shock. I will also emphasize the pathophysiologic mechanisms that underlie shock. And then the last thing that we will do is use of evidence-based guidelines to institute appropriate fluid and vasoactive therapy. For me to accomplish the first objective, I've decided to just play a video that describes everything that you'll be interested in. Am I coming with you? Okay, so we're having some technical issues here, so bear with me. Because of the 15 minutes to speak about shock, what I decided to do was to put the first 8 minutes of this talk on a video that would describe the pathophysiology of shock and the different types of shock. And then I will spend the rest of the time talking about the management of shock. While we are waiting, in general, shock describes circulatory failure where oxygen delivery does not meet tissue metabolic demands. So there's a mismatch between oxygen delivery and the metabolic demands of the body. So most of the times we describe shock as a circulatory failure. And to be honest with you, that best describes it all. Either you have distributive shock because there is adequate cardiac output, but blood flow to the major organs are maldistributed. And of course, you can have cardiogenic shock, which means primarily the heart is not functioning very well. And because the heart is not functioning well, then you have very limited delivery of oxygen. So if you have impaired oxygen delivery, as a result of cardiac failure, you can also develop cardiogenic shock.
Switch to talking about shock. Shock, or circulatory failure, is defined as inadequate delivery of oxygenated blood to the tissues to meet metabolic demands. So it's an imbalance in demand and supply. If you look at the components of oxygen delivery, it is a combination of the cardiac output, or liters per minute of blood flow that the heart is pumping, and the arterial oxygen content, how much oxygen can be carried in a milliliter of blood. In most patients, the contribution of dissolved oxygen is very small compared to oxygen carried on hemoglobin. But in the case of severe anemia, the contribution from dissolved oxygen may be significant. Going further into these hemodynamic relationships, oxygen delivery is in part dependent on cardiac output. Cardiac output is a combination of a patient's heart rate and stroke volume. That is the volume of blood ejected with each contraction of the heart. Stroke volume has three contributing factors. One is preload, which is the volume of blood that's in the ventricle prior to ejection. Another is contractility, which is the strength of the ejection. And the final one is afterload, which is the resistance against which the heart is pumping. Another way to look at that is that that's the arterial blood pressure against which the left ventricle is pumping. That are very uncommon, we're going to focus on these. The first is hypovolemic, and the primary problem there is low cardiac output due to low preload. The patient will compensate for hemorrhage from trauma. Distributive shock, its primary derangement is low systemic vascular resistance, and there may also be a degree of capillary leak leading to low preload or hypovolemia. So distributive shock can have several characteristics of the other forms of shock as well. When SVR is low, the initial response of the body is tachycardia. Unfortunately, because of the presence of toxins or other substances like inflammatory markers from anaphylaxis, one isn't able to then reverse that low SVR, and it remains in a vasodilated state. Examples of this are sepsis and anaphylaxis. Finally, cardiogenic shock. The primary derangement is low contractility from a number of different potential causes. And the compensatory mechanisms are tachycardia and vasoconstriction, or increased SVR. Examples of this are a patient with myocarditis or someone who has suffered a cardiac arrest and whose heart is not functioning well. You can see that hypovolemic and cardiogenic shock can look very similar in terms of the clinical signs, meaning their compensatory mechanisms. But a patient with hypovolemia typically has a history or an exam that suggests why they have inadequate preload. And a patient with cardiogenic shock typically lacks that type of history and may also have signs of congestion, like hepatomegaly. When you consider all types of shock, there are some signs in common with some differences depending on the specific etiology. Tachycardia is almost universally present, with the exception of neurogenic shock, which may happen from spinal cord injury. Most forms of shock result in increased systemic vascular resistance, or vasoconstriction, the exception being septic shock or anaphylaxis, where there is profound vasodilation. When you have increased SVR, the physical signs include cool extremities, delayed capillary refill, and diminished distal pulses. You will also see signs of end organ dysfunction. For instance, changes in mental status, such as confusion or agitation, which could progress to lethargy or obtundation. And over time, decreased urine output. When there's inadequate oxygen delivery, the resultant metabolic acidosis leads to tachypnea in an effort to compensate with a respiratory alkalosis. Finally, hypotension, which is a late sign of shock in most situations, may occur. Now, one has to keep in mind a very common form of shock in hospitalized children, which is septic shock, sometimes also referred to as warm shock. Here, the primary derangement is low systemic vascular resistance, and there is compensation with tachycardia. But because of the low systemic vascular resistance, the patient, instead of having cool skin, has warm skin, may even appear flushed. They have strong or bounding pulses and brisk capillary refill, because this is a state of vasodilation. The problem being that too much blood flow is being sent to the periphery and the skin and not enough to the vital organs. So one still sees impaired end organ function, such as changes in mental status or urine output, and development of metabolic acidosis and compensatory tachypnea. Hypotension can be an early sign of shock in the setting of sepsis because of the vasodilation. This illustrates those relationships, again, multiple forms of shock with compensatory mechanisms leading to compensated shock, ultimately decompensated or hypotensive shock, which can rapidly progress to cardiorespiratory failure and cardiac arrest. To remind you, cardiorespiratory failure occurs when shock is left untreated, leading to both respiratory failure and shock. Signs of cardiorespiratory failure include decreased respiratory effort, cyanosis, bradycardia, and unresponsiveness. In summary, it's important for pediatric providers to be able to recognize shock and respiratory failure, which are the two.
So what I'm going to do now is just to go ahead and talk about the management of the different types of shock. In summary, you have hypovolemic shock, which for us here might be predominantly from diarrhea and gastroenteritis, and also probably from massive blood loss. Then, of course, you have distributive shock, which is primarily from sepsis, and of course, cardiogenic shock. Those are the three shock categories. And they all share a very common pathophysiologic mechanism. The one thing I want to say here is tachycardia for us in critical care is not benign. You can see from this slide that most pediatric patients in shock, they have the ability to maintain their systemic vascular resistance. So anytime you see a child who is tachycardic, even though the blood pressure is normal, you have to ask questions. So let's go now and talk about, I'm trying to change the slide, it's not changing. Well, for sake of time, I will just continue here. The few things that is not mentioned in that slide, there are a lot of things in pediatrics that can present like shock, that is primarily not septic shock. For example, congenital heart disease. Patients with ductal dependent circulation, like coarctation, and critical aortic stenosis, they can present in the newborn like shock. They will be very lethargic, they'll have metabolic acidosis. It is very important to note the difference, because if you are dealing with a congenital heart disease patient who is presenting in shock, you have to make sure to, as much as possible, to give Prostin and actually minimize the use of oxygen, because you want to maintain ductal patency. The other thing that may look like shock that is not shock are inborn errors of metabolism. A patient with urea cycle defect, they will be obtunded, they will have metabolic acidosis, they will have extremely high ammonia levels, and they will have cerebral edema. So all these ones can look like shock. Yeah. So let's go to the treatment now. In that video, you saw the different types of shock. I want to talk about the management now quickly, using the Surviving Sepsis Campaign algorithm. It's very important for us to see this slide, because the way this lecture was structured is that the video will introduce you to the general concept, and then I will talk about the management. Where is the with this? Technology.
BCC, I need some help, please. Come on.
So please look at this diagram. Regardless of the type of shock, hypovolemic, cardiogenic, distributive, this is the surviving sepsis campaign guideline. Time is of essence. Within the first hour of making a diagnosis of septic shock, those are the things that you have to accomplish. Obtain IV access, collect blood culture, start empiric antibiotics, measure lactate, administer fluid, and start vasoactive agents. Now, if you are in doubt, if you are suspecting sepsis, within 3 hours, you should be able to accomplish the same goal. So there are two issues here. The patient that is convincingly with septic shock and the patient that you are still suspecting that may have septic shock. And then, of course, when it comes to fluid management, because of time, fluid management, there has been a lot of changes. Typically, you give 10 to 20 cc's per kilo of normal saline boluses, and you can repeat that up to 40 cc's per kilo. But this is the problem. If you are University of Ibadan, when you have emergency room and you have ICU, you can give fluid up to 40 per kilo. But then if you are in Moniya somewhere and you don't have ICU bed, this recommendation is saying you should be very careful with how quickly you give fluid. Because if the patient goes into pulmonary edema, needs an airway, you don't have the capacity to take care of that. So for that reason, they divided the patient, a patient who have poor perfusion but has a normal blood pressure, you can start them on maintenance fluid and start your inotropes. But patients who are hypotensive, low blood pressure, you can give them fluid. But the way I kind of interpret this is, if you are in a practice setting where you don't have ICU support, be very careful with how you give fluid to your patients. This is a study that was actually done in Africa. that shows that patients who receive massive fluid boluses actually had a higher mortality. And the reason they had a higher mortality is that if they develop complications of treatment, they did not have enough ICU to support them. These are the common resuscitation fluid. Dextrose is not to be used as a bolus. However, in your patient with shock, particularly pediatric patients, point of care glucose level is important. You need to check the glucose, and if there's hypoglycemia, you give glucose. The rest of the slide is showing you isotonic fluids that you can use for resuscitation. I'm going to have to move very fast. When it comes to vasoactive infusions, the options are epinephrine or non-epinephrine. Now, the guideline says epinephrine is the preferred vasoactive agent if you are dealing with cold shock. Cold shock is a patient that is in shock, defined as poor perfusion with evidence of end organ dysfunction, acidosis, low urine output, altered mental status, but then they maintain their blood pressure because of a high systemic vascular resistance. Those patients, you can give them epinephrine. But then the so-called warm shock, which we see a lot in pediatrics, are patients who have hyperdynamic circulation, they have brisk cap refill, they have fever, and they have a very low systemic vascular resistance. Those patients, you need to put them on norepinephrine because you want to maintain a high systemic vascular resistance. Then supportive care, high flow oxygen should be given to such patients. Oftentimes, patients in shock invariably might need to be on mechanical support. However, if you don't have an ICU or you don't have enough ventilators, you can support them with supplemental oxygen and non-invasive mechanical support, like high flow oxygen or BiPAP. But these are all the options that you have. Definitely, your low flow nasal cannula is inadequate. You want to use a non-rebreather, or you want to use a high flow nasal cannula. If you have to intubate a patient in shock, our anesthesia colleagues will tell you your choice of medication is important. Atropine for pediatrics patients is important because they will develop bradycardia once you try to intubate them. Ketamine is a good drug of choice for intubations. And if you have to use neuromuscular blocking agent, you have to be sure that you can obtain an airway. What are the ancillary laboratory studies that must be performed? Number one is point of care glucose, blood cultures, full blood count, your E&U, ionized calcium, type and cross, coagulation profile. If there is a central venous line, you can do your superior vena cava saturations. I don't think we need to worry about that in our environment. Blood gases, checking lactate levels to help you monitor your response to treatment is important. I don't know if we can check lactate routinely in our practice setting, but a patient with metabolic acidosis in the setting of shock invariably has a high lactate level. And if you are very successful with your resuscitation, you will see a resolution of the acidosis. Essential monitoring, pulse pressure, which is typically wide in distributive shock and narrow in other types of shock. Temperature control is important. Hypothermia or hyperthermia should be avoided. Urine output. If your resuscitation is effective, you will see an improvement in your urine output. So most of these patients will have a catheter in place. The urine output is a surrogate for cardiac output in this patient. what do you want to accomplish when you are resuscitating the patient? Number one is to restore threshold vital signs. If the patient is hypotensive, you want to at least get their perfusion. In pediatrics, we kind of go by the mean arterial pressure. Even in adult medicine, you want to get it to the normal range. For patient less than 12, it's above 50. For patients in between 12 and 5, it's about 60. And older patients, you want to maintain a mean pressure about 65 and above. So that is important. Normal mentation. You can see improvement in mental status if your resuscitation effort is successful. Your capillary refill time, which might be increased initially, becomes very brisk when the patient improves. Then the distal pulses, strong distal pulses, those are the things you want to look out for when you are resuscitating this patient. Now, most of our speakers has emphasized the importance of time when you are dealing with life-threatening situations like shock. So you can see minutes counts the diagnosis. M there stands for maintaining ABC. Be aware of the possibility of tension pneumothorax and decompress that. Also stopping major bleeds. The IN in minutes, infuse, investigated. Start infusion of vasoactive drugs very early, and also start your investigations, like all the blood samples that we talked about. Ultrasound to detect the type of shock. That is important. And ET there stands for treat the underlying etiology. Find out what is causing shock and try to treat that. And then finally, stabilize the organ for perfusion. So this is, within the first 30 minutes, these are the things that you have to accomplish. I will stop there, and in summary, pediatric shock can be hypovolemic, distributive, or cardiogenic. Distributive shock can be septic, and it could be spinal shock. And the treatment of choice depending on what kind of shock, but primarily you need to restore intravascular volume and support the patient with vasoactive agents like your epinephrine, which we call adrenaline here, or norepinephrine. In the administration of fluid, remember that you have to constantly check for evidence of fluid overload. Listen to the chest for crackles. Why? Because the patient might end up needing mechanical ventilation. If you do not have mechanical ventilation, that will increase the mortality. Thank you.
Let's give a round of applause. Our next set of presenters are online, and it's my pleasure to welcome Professor Rotimi Jaisimi, who will be talking to us on adult sepsis. BCC, please connect to the Zoom. Professor Rotimi Jaisimi is an obstetrician and gynecologist practicing in the United Kingdom. Let's once again give a round of applause.
Good afternoon. I'll be with you in a minute. Good afternoon, and I stand on existing protocol, but would like to acknowledge the presence of Emeritus Professor Wole Akunde, my teacher, then Emeritus Professor Sam Omokodian, Dr. Bode Williams, the President of Imsg-Uk, the CMD UCH, CMAC UCH, and the Provost of the University College of Medicine. So thank you for inviting me to speak on adult sepsis. My colleague has made my work easy because he's spoken about pediatric sepsis, and the only difference in most of that is due to the physiological changes. Just to say, I'm a proud Ibadan graduate, 1978. So we'll go straight into the matter. Adult sepsis. In emergency care, which we heard today, and trauma care, we usually speak about the golden hour, and it's the same in sepsis, whether it's adult, pediatrics, or maternity. So recognition is important, diagnosis and early management is important. I practice in the UK, and our practice is based on the updated NICE guidelines, number 51. And that's what I'll be speaking to you about today. Now, this is just a slide that summarizes what I've just told you, that why do we just say adult sepsis, pediatric sepsis, and maternal sepsis? We differentiate them because of the different physiological changes that occur in pregnancy or in pediatrics or young children. And that's the main reason why this topic has just been termed as adult sepsis. In the United Kingdom, we take the age of 16 and above as adult. And it was interesting to hear this morning, a few hours ago, that if you have got to the puberty, then you consider that as adult. Well, that's interesting, which we would also look into because we learn each day. Now, what is sepsis? It's a life-threatening condition where the body fights against itself in response to an infection. And it's becoming a public health issue. We're just beginning to realize that it's a public health issue globally, not just in the UK, but also in Nigeria, in Africa, low to medium income countries. In the United Kingdom or England specifically, we've got almost 250,000 cases annually, and the mortality rate is 20.3%. So it causes more death than leukemia, breast, bowel, and prostate cancer put together. But you will hear a lot about prostate cancer, breast cancer, leukemia, and to a lesser extent, sepsis. And because of this high rate, that's why now people are talking about sepsis. Think about sepsis when a patient is very unwell, whether young, whether it's in pediatrics, maternity, or adults. Early recognition and treatment within 1 hour, the golden hour, significantly reduces mortality. But again, that has changed slightly. The 1 hour now applies to low-risk people who have been classified as low risk. But medium to high risk is 1 hour. For the low risk, it's been changed to 3 hours. And it can affect anyone, as we've seen. And time is critical. Every hour delay in antibiotic administration increases mortality risk. So the high-risk groups are people who are elderly or very young, people who are immunocompromised on cancer treatment, people who've had invasive procedures. We all know the risk of surgery, which includes infection. Patients with indwelling lines or urinary catheters, breaches and skin integrity. So even a minor cut to the skin, if it becomes infected and it's not well managed, can snowball into becoming septic, and then you get sepsis shock. Pregnancy, we wouldn't be talking about. Then IV drug users, which is common globally, can be a source of infection. And these are high-risk people. And so we've got to maintain a high degree of suspicion when anyone presents with signs of infection, particularly in this group of people. When we talk about the elderly, they can have signs of disorientation. And I know in my area, when I say my area, I am Nigerian. When you have an adult who is behaving irrationally, people start thinking that they are either witches or whatever you want to call them. No, you've got to be careful that they are not. It might be that they've got sepsis, they are highly unwell, so they are disoriented. So the red flag, we call it the red flag sepsis criteria. Any one of the following indicates or suggests high-risk sepsis. So as I alluded to just now, altered mental state. They are not going mad. Acute confusion. They are not going mad. Response only to voice or pain, or they are even unresponsive. That's at home. Or if somebody says, I haven't passed urine today, or my urine volume has reduced, it's a sign that this could be septic shock. In the United Kingdom, we talk about non-blanching rash. I don't know what we'll see in black people. As somebody interested in equality in medicine, we are looking at how to describe non-blanching rashes. Then when we talk about respiration, when they come to the hospital, a respiratory rate of 25 and above is suspicious. The need for oxygen is important. And then cardiovascular, systolic blood pressure below 90, heart rate pumping 130 beats per minute. And again, the skin changes that can occur. So when you notice any one of these in patients or a combination of these in patients, then you've got to wonder, ask yourself, could this be sepsis? Now, in the United Kingdom, like I said, NICE Guideline 51, updated in 2024, has now stratified the risk of sepsis. And we have a scoring system, which is called National Early Warning Scores, that takes into account the physiology, blood pressure, heart rate, the temperature, the oxygen, amongst others, in scoring the patient. And you can see a score of 0 is low risk, and the action is to continue monitoring the patient. And going down this slide, a score of 7 and above is high risk, and they need emergency, not even urgent, emergency assessment and therapy. So clinical judgment still remains paramount, and the tool, which I've just described, is to support us as clinicians and not replace our decision making. Now, antibiotic administration timing, like I said, it's now changed. High-risk people should get their antibiotics within 1 hour of identification. Whereas with medium risk, that is the score of 5 to 6, you can give antibiotics, ensure you give antibiotics within 3 hours. Whereas in low to medium risk, a new score of 1 to 4, assess the patient to determine whether they need antibiotics. We've got to be careful because we all know of the global problem of antimicrobial resistance. So if a patient doesn't require antibiotics, don't give antibiotics. And if you do give antibiotics when you have a suspicion of sepsis, when your investigations come back and it doesn't suggest or point towards sepsis, then you step down your antibiotics therapy so that we don't promote antibiotic resistance globally. So what tests do we do? Normally we say you've got to take what you have to do, blood tests, blood cultures taken from 2 sites before you give your antibiotics. There's no point giving antibiotics then now taking blood for culture. As you heard earlier on, full blood count, urea and electrolytes to assess renal function, or AKI, lactate if it's available locally, prolactin as well, or procalcitonin, not prolactin, procalcitonin if it's available locally. I believe we have CRP in Nigeria, we can do that. And as you heard earlier when we were discussing the pediatric one, there's a potential of coagulopathy occurring, and that's why we do a coagulation screen, including blood glucose, liver function. And other tests include urinary function, urinary test to exclude infection, more so in adult people. UTIs are a known cause of sepsis. Then arterial blood gases, if indicated, a chest x-ray, more so depending on what the history is it a chest infection, and then you do a chest x-ray, and other cultures as necessary. Now, you will hear of the sepsis 6 bundles. It's about what do you do. First and foremost, within the first hour of recognition, you haven't made a definitive diagnosis. You give high oxygen to the patient. 94 to 98% is what we are aiming to get. In patients with chronic obstructive pulmonary disease, you aim for a lower level of oxygenation. Take take blood cultures, as said before, then you give your antibiotics as per local policy. You've got to have your antibiogram to know what is sensitive to different organisms in the area where you practice. Then you give IV fluid for resuscitation, 500 ml bolus over 15 minutes. This you did here when we were listening to the pediatric aspect. And I think I haven't mentioned lactate as well as urine output. I wouldn't go too much into fluid resuscitation, but it is important that after each bolus, you reassess again. Is the patient responding to treatment? That is the blood pressure rising? Is the heart rate going down? What's the urinary output? And what's the mental state of the patient? You will only continue fluid boluses if the systolic blood pressure remains below 90 mm of mercury, or if the signs of shock persist, or if the lactate is above 2 millimoles per liter. But we must exercise caution. Again, you did hear that with the pediatrics. You do not want to overload the chest. Now look out for where's the source of infection. If it's an abscess that requires drainage, then you put that into place. Now, sepsis kills. That's one thing we need to know. And it's very essential that senior colleagues, senior doctors are involved early in the management of these patients. Rather than leaving the management of the patients to resident doctors, SHO, house officers, it is very important that when you think of sepsis, and you think most of those who are very ill, that you involve the senior clinicians, consultants, renal physicians for acute kidney injury, or if there's respiratory failure, they may have to get them into ITU, intensive care unit. And if there's a reduced level of consciousness, again, the more reason why a senior clinician should be involved in the management of the patient. Monitoring, I cannot but overemphasize the need for doing this. So I will not go into neutropenic sepsis. These are patients on cancer treatments whose neutrophils go down, and they are susceptible to sepsis. They have their own guidelines, specific guidelines for neutropenic sepsis. So you can see, refer to NICE guideline on neutropenic sepsis. This is different from adult sepsis. Older people may not develop fever or have typical signs. Changes in cognitive function may present as acute functional changes. They haven't got Alzheimer's or dementia or being mad or being witches. In patients with spinal cord injury, they mentioned temperature may not rise with infection. Autonomic dysreflexia may mask typical signs. Monitoring is very important. Communication is important between clinicians, and when I say clinicians, I'm talking of the nurses, I'm talking of the healthcare assistants, I'm talking of the doctors. We are all in one team, and we need to know exactly what is going on. And we must keep and treatment being given. And where possible, if you have the information leaflets, give it to them. Communications between teams using the SBAR handover tool, which I'm not going to go to in depth, is a simple tool. Situation: this patient has suspected sepsis. The background history, temperature, risk factors, suspected source, if you know it, assessment, observation, news score, and the investigations you've asked for. Then the recommendation. What treatment have you given? Is escalation to senior people required? That is implication. Communication as well as documentation are important things when looking after patients with sepsis. And you might think, oh yes, we successfully treated the patient, they survived, but there is, just like you have long COVID, there are patients who survive sepsis who also have issues when they go home. Also, for example, if the kidney has been damaged or there's been damage to the lungs. So when they're going home, you provide them with information about what they had gone through and the recovery timeline, explain signs of deterioration, because at times you discharge them and they get worse and have to come back into hospital. You've got to let them know that and see them at follow-up. So all training, I'm just going to summarize this slide. I see medicine as apprenticeship. Training and education is important. Just like we're having today is a training, one of the training modalities we have is a webinar or a seminar, and we cannot but overemphasize the need to continue with our professional development. The take-home messages: sepsis kills. It's a medical, have a high index of suspicion. When patient was feeling unwell, and in the UK, if we don't already have one, how do you stratify sick patients? And time is of the essence. We've spoken of the golden hour.
As your job trust. So if you want to involve yourself in other parts of resuscitation and you think you don't want to continue holding the jaw, you can put in an oropharyngeal airway. Oropharyngeal airway helps to dislodge the tongue from the oropharynx. Again, it's depicted in the picture as shown on your screen. The tongue can easily become floppy and obstruct the oropharynx. So when you put in an oropharyngeal airway, it helps you to overcome that problem. Oropharyngeal airway should not be applied in people that are conscious and people that potentially have gag reflex, because you are going to stimulate vomiting in the patient, and you don't want that, because if the patient that is struggling with the airway vomit, it can go straight into the lungs and cause more problems for you. So make sure that if the patient, if you are about to insert it and the patient starts coughing or they are having signs of laryngospasm, just take it out. Now, if the patient is tolerating your oropharyngeal airway, it means that you have to plan for a more definitive airway, which I'm going to speak on later. Now, these are pictures of laryngeal airways. They are generally referred to as supraglottic airways, which means above the vocal cord. The commonest here in the UK is the IGL. I'm not really sure what's up in Nigeria currently, but we have the laryngeal mask. These devices are designed to help us overcome obstruction at the level of the epiglottis. Again, the epiglottis just contains smooth muscle that can become very floppy and obstruct the laryngopharynx when a patient is not fully conscious. So if you put in a laryngeal mask airway or one of these supraglottic devices, you are going to overcome that obstruction and deliver oxygen to your patients. Now to definitive airway. The common definitive airway we are all familiar with is the endotracheal tube. And a definitive airway is achieved when a cough tube is placed
Okay, welcome back. Good afternoon, everybody. Thank you for coming back in and bearing with us. We're almost done with the lectures. There's just one final lecture left, which is mine. So, Joe, I'm trying to get through this. I know it's hot and everything, but I really do want to make sure I give this lecture. Thank you to all the speakers that have gone ahead and for the fantastic expert talks. I'd like to acknowledge some of our dignitaries in the hall today. I want to say welcome to Mr. Shina Fawole, who's a consultant surgeon, Mid-Yorkshire in the UK. You're welcome, sir. I understand he finished his 1991 set, sir. Some of you were, well, anyway, never mind, leave that. I also want to acknowledge I finished from Federal Government College, Ogbomoso. Yeah, FGC Ogbomoso. And I currently serve as the Board of Trustees Secretary for my secondary school. So we're giving back to my school as well, and we support that. Our member of our Board of Trustees is here supporting me. Our magistrate, Olasimi Bo Sanusi, she works here in Ibadan. Magistrate, you're welcome, man. Thank you. And thank you to all FEGO alumni who are online and who are supporting me as well. Thank you. I want to say a special thank you to my class of 2002. We call ourselves the people of UCH 98. We crossed over, we got into UCH in 1998. We're a cohesive force. We're a very strong family. We do a lot. We mentor, we give scholarships to students here, we give back to the school. A lot of them are online. So just a quick shout out to Pouch 98. Thank you for joining. I see you all. I'm going to start with my wife. She's online. Dr. Jaye Olaleye, thank you. Thank you for joining. Okay. I'll have to, thank you.
Sound check. I should use it too. Okay. I'm doubly mic'd up now. Dr. Matthew Oluwole, thank you. I see you. Professor Rotimi Jayesimi, who gave a beautiful talk. We appreciate you. Dr. Petros, Pouch 98. Adegboyega Kintunde, who's given a beautiful talk. He's actually set me up well because he's talked about non-surgical airway management. Yeah, so everybody online, we appreciate you. Those of you in the room, we appreciate you. Okay, so I'm going to talk to you about surgical airway management. Can my slides be projected, please? Okay. So I'm Dr. Oladejo Olaleye. I'm a consultant in ENT, head and neck, and robotic surgery. I lead the robotic surgery program for the University Hospitals of Leicester.
taking out cancers of the throat, neck, thyroids. Thank you. I'm an honorary associate professor. I do research on cancers in the Leicester Cancer Research Center, University of Leicester, and I serve as the Education and Research Secretary for the Ibadan Medical Specialists Group that has put together today's symposium. I lead my class of 2002, so I'm the Executive Secretary for my class. So I wear a number of hats, so it's a pleasure to be here. Thank you. So I'll be talking to you about surgical airway management, which is what I do on a daily basis. And I'll be talking to you first about tracheostomy. Because although there are management levels for the airway, cricothyroidotomy, tracheostomy, sometimes we do awake fiber optic intubation with the anesthetist. But I think a tracheostomy is by far the commonest intervention that we do as surgeons, both here in Nigeria and anywhere else. So I'll talk a bit about the indications for tracheostomy, different sort of tracheostomy tubes that we have, step by step the procedure, and just post-procedure care. So indications, we want to secure the airway in an upper airway obstruction, and anything could obstruct the upper airway. You could have trauma, road traffic accidents, falls, injuries, that could cause facial fractures, laryngeal fractures of the airway, and A comes before B, before C, before anything else. So A is for airway. And Dr. Adegboyega Akintunde has done a beautiful job talking about removing secretions, blood, making sure the patient can breathe. So airway is quite important, but particularly when you have fractures, things might not be clear. There might be blood, the anatomy might be difficult, so you need to bypass that with a distal airway, often a tracheostomy. The anesthetist may struggle to intubate if you've got active bleeding. And I've seen situations where it's really difficult. The trouble with blood is laryngospasm. Once the blood goes down, the patient spasms, they go blue, and you don't have much time. So you do have to do a tracheostomy or cricothyroidotomy very quickly. Sometimes there are cancers that block the upper airway. I treat patients with cancers of the head and neck area, and sometimes there's a cancer of the tonsil or tongue base or larynx, particularly larynx, because it can grow on the vocal cords and block breathing. And they can come in end-stage disease, so sometimes we do have to do, often we have to do a tracheostomy. Severe infections, epiglottitis, supraglottitis, in children, in adults. It's not as common now in children because of the HPV vaccine. However, we do see a lot of supraglottitis in adults as well. So once you've done your standard things with sepsis, which Prof. Jaisimi has talked about, with starting antibiotics on time, once you've taken your bloods and cultures, you do need to think about securing the airway. And there are steps to that. Is the airway intubatable? Can you get away with just steroids and antibiotics? Do you have to intubate the patient and look after them on an intensive care unit, or do you have to do a tracheostomy to protect them? So it's often about protecting the airway from bleeding, secretions. The most common indication is weaning them off a ventilator. So once a patient is on the intensive care unit, 7-10 days, intensivists start asking you for a tracheostomy to protect the lungs and protect them from ventilation-induced injuries to their lungs, damage. You want to try and mobilize them. You want to try and assess their neurology, their GCS. So you want to put in a tracheostomy to wake them up, basically, and see what they do. Some patients have neurologic impairment. That means that their central control for breathing has been affected. And in that case, once you work with your neurologist and intensivist, you might need long-term wean with a tracheostomy. The work I do see patients who have cord paralysis. Sometimes it's bilateral. And the trouble with bilateral vocal cord paralysis is that the patients get stridor. The cords don't open. It's in adduction, so the cords are closed. So they get stridor. They can't breathe. And in that case, you will need to do a tracheostomy to protect them, allow some recovery time for the vocal cords to come back to functioning. You may even get vocal cord paralysis following any complex head and neck surgery or thyroid surgery. And there are times when, after total thyroidectomy, for example, where we've been working around the recurrent laryngeal nerves, due to stretch, you might have bilateral cord palsy. And that can happen 2 out of 100 cases that I've done. And you have to be ready when the patient is extubated to do a tracheostomy in that case. And there's some complex head and neck surgeries as well with cancers in the neck, with neck dissections, or just doing flaps. When you take out cancers in the tonsil, tongue base, you reconstruct with the radial 4 and 3 flap reconstruction. The tongue isn't moving, you've put a bulky flap in the tongue. You want to protect the airway, allow the edema to settle. So these are some of the common indications. I put a picture up here just so we can relate with what I'm trying to say. It's important that you understand the difference between a tracheostomy and a laryngectomy. Laryngectomy is when we've removed the entire larynx for often cancer reasons, okay? So there is no voice box, and it's important that students, you understand that when you go to resuscitate a patient who's had a laryngectomy, okay? Is that it? Okay, I'll give that.
Just continue. Yes, we can.
When we put in a tracheostomy. Thank you. So these are the different tracheostomy tube parts. You need to understand the different types. So when you put in an initial tracheostomy tube and there is bleeding in the upper airway, you want a cuffed tube or secretions, or the patient can't manage their own secretions. A cuffed tube is what we often put in. And you could see the cuff on the picture there. We put in some air in the balloon. You check that the pressures are fine, and you make sure it's secure. We talk about fenestrations when we want the patient to voice. We want air to come from the lungs and come out through the tube and through the mouth. So voicing options, fenestrated tubes. There are inner tubes that you need to be cleaned because it crusts up, and sometimes that itself can cause an airway emergency. If you imagine that the inner cannula completely blocks off and you're the student or the house officer that goes to the side of the patient, you need to take that tube out, you need to remove the crust, and that's when the patient can breathe. So these are the sort of the different parts of tracheostomy tubes. And you would have cuffed tubes, uncuffed tubes, pediatric tubes, adult tubes, the ones that are, extra length, depending on the patient's habitus, their BMI, just make sure that you can get down. And then these are some of the sort of pediatric tubes that we have as well. Some are cuffless, often for kids, for obvious reasons with the tracheomucosal injuries. There are different tube sizes depending on the weight of the child, how old they are. So newborns, you have to be very careful, particularly if they're preterm, and children based on their weight, 5 to 8 kilograms. You need to look at the internal diameter of the tube that you're trying to put down. And you need to make sure that before you start a tracheostomy, you have the right appropriate tube size and a size below that, because you may struggle to put it in, and that is not the time to start going anywhere else to look for a tube. That tube has to be on your tray, a smaller tube size to rescue the patient. And I've been in all sorts of situations, so it's important to prepare. For adults, generally men, size 8, internal diameter, size 8 trachea tubes are fine. For women, size 7. This is the sort of anatomy that you get. Your thyroid cartilage, your cricoid below that, and often I would make a window between 2nd and 4th tracheal rings. You don't have to make a window. You can make a vertical slit in an emergency, For kids, we make a vertical slit. You pull through with sutures on either side and stay sutures in children, because long term you could have tracheal stenosis long term. So in terms of what you want to do, so you want to make in terms of preparation on your tray, you want to make sure you have the appropriate tracheostomy tube size. You have checked that your cough is working. I should carry on. You've checked that your cough is working. You want to make sure that you are ready for skin, local anesthetic infiltration. You've got your scalpel, your mosquito, you've got your retractors, and you've got suction on the ready, because once you enter into the airway, you will have secretions come up. And you want to dissect from skin, subcutaneous fat. You want to retract the straps. You want to take away whatever is on the trachea. Often, you may come across the thyroid isthmus in the middle, which is like a bridge on the thyroid gland. So you have to be ready to divide the thyroid isthmus. You can do that with any heat instrument that's available, bipolar diatomy, unipolar diatomy, ligature. You could do a standard tie and just expose it. I call it an open book. You want to open a book. You want the two flanges of your thyroid to be away. So you make sure you divide the thyroid isthmus. Some patients have a large goiter in front of their neck, so be ready for that. If you can't do that, you might need to hook the trachea up to get access. But it's often good to divide the thyroid isthmus to get this picture here. You want to be able to see the trachea, and we often go for the second 2/4 tracheal rings to make a window. So you cut out a window, and then you put your tube in there. Now, you need to control bleeding as you go along. It's often best to do this bloodless from start to finish, because once the tube goes in, visibility is less, and it's more difficult to manage bleeding. So again, just the steps. So you look for your landmarks, your sternal notch, the cricoid, the chin. You go halfway between your sternal notch and your cricoid landmark in most patients. So you make a neck crease incision with your knife after infiltrating with local anesthetic. You raise a subplatysmal flap if you can, either with unipolar diatomy or bipolar, or even a knife. Your aim is to go in the midline bloodless raphe that you have in the neck, if you can. And you want to divide the straps. So this just shows division of the straps. You want to pull the straps away with a Langerbeck or your assistant. Your assistant has to be awake and alive to what you're trying to do. Stay in the midline. Is often bloodless, aside from the inferior thyroid vein that comes from inferior leak, which you need to deal with. But often the midline is bloodless. You want to do some blood dissection all the way down to the trachea. So always put your finger on the trachea. Make sure you know where you are, and make sure it's not a calcified carotid artery or anything like that. So put your finger on the midline, trace the trachea out, skeletonize it, divide the thyroid isthmus, as I've said. And once you get onto so this is using a mosquito or a forceps right on top of the trachea to get down onto the anterior surface of it. Your assistant is retracting with the Langerbeck retractor so you can see the trachea. And there are often tiny tissues on the trachea there that you need to just get rid of. We're aiming for the 2nd to 4th tracheal ring is what we're trying to find. You will find your cricoid because it's a hard ring. But below that, you want at least the 2nd ring. If you go too high, then the risk of stenosis is higher, it's harder to do. So often I would make a window. Now this is a child, so we put Prolene stay sutures either side because they're going to get a vertical incision. And you could use a vertical incision in an emergency. You don't have time, a patient has gone blue, you're there in A&E or resource, you need to just go midline, all the way down to that trachea and open it up and get your tube down. You can then deal with bleeding and all of that once the patient is resuscitated. A vertical incision is made with the stay sutures in place around tracheal rings 2 to 3. And sometimes you might need to use tracheal spreaders if it's too difficult and you can't get the access that you need. Sometimes you might need to use a hook, particularly in adults. If you make a window, make sure you make a good enough window. There's no point trying to force a tracheostomy tube through a small window. You will struggle, you will lose time, and it could be patient critical. So make sure that I often tell my trainees, make sure that your access is good. Sometimes when you put the tracheostomy tube in, the edges of the tracheal window might actually burst the cuff. So you might find that although your tube is in, your cuff doesn't come up when you put pressure through it. You will need to replace that tube to make sure you don't have secretions going down. There are all sorts of different tubes. This is a pediatric one, so you've got your Shiley, Portex, there are lots of ones available. But make sure that before you start, you have checked your tube, it's on the tray, the cuff is working, you have a smaller size tube. This will save you. There's a smaller size tube on the tray. There have been scenarios where, for whatever reason, the tube didn't work. You just get the smallest endotracheal tube and just put it down. Rescue the patient, and then you can put a tube in. So Shiley tracheotube was placed in this child. Once that is placed, you want to secure bleeding. If there's any bleeding around, it is critical. Communication is critical. Not so much the surgery. You're trained to do that, but you have to communicate in this sort of emergency or putting in an airway. Airway is time critical. You have to speak to your anesthetist. You have to check whether they are ventilating. Once your tube has gone in, the first question, I'm looking at the CO2 trace. I'm trying to see, is CO2 coming through that tube? Is the anesthetist happy? Are they ventilating this child or this adult? Because there have been scenarios where we've put the tube in, maybe it's not in the right place, maybe it's dislodged, maybe there's a clot, maybe there's something. So your tube goes in, you need to be asking the anesthetist, are you ventilating? Is your CO2 trace working? If it is, then you're fine. If it's not, you have to make sure that A, the tube is in the right place. I've seen displaced tubes anterior to the trachea because of the curve. And if you don't recognize it, the patient will die. So you can have a look, you make sure you suction. So there are flexible suction catheters that you put down, get rid of any blood all the way down to the carina. If you're still not sure, if you've got a flexible endoscope, you could put an endoscope down to have a look and make sure you can see the airway down to the carina. Patients have died for lack of diligence in this regard. So communicate with the anesthetist, make sure the airway is patent, and secure it. There are straps around the tracheostomy tube that can go around the neck, flexible straps. Sometimes I suture the tube in place, particularly if the patient is going to the intensive care unit, because of all the manual handling and moving them around. Sometimes it falls off, and then they call you in an emergency. So this is sort of securing the tube in this case. A fiber optic examination, if you have it, is a great tool. I always have it in my theater because it's helpful to put you can see them putting the camera down just to make sure that A, it's patent, and B, there's no clot, the tube is in the right place, it reassures you and the anesthetist, and make sure it's the right fit. If you put in a trachea tube that is too long, you may end up with an endobronchial intubation. That means you've pushed the tube into one of the main bronchi, the left or the right main bronchi. So you'll be ventilating one lung. That's no good for the child or the patient. You have to recognize that at the time, because otherwise you have a collapsed lung and you cause more problems. There can be complications with tracheostomy, pneumothorax, so you have air in the cavity due to the pressures. So we always do a chest X-ray once you've done a tracheostomy tube, just to make sure that you've got there's no pneumothorax, there's no hemothorax or blood. You'll be rather unfortunate if that happens. But bleeding, emphysema around the neck. So we do a chest X-ray afterwards once it's secured. Now, in terms of a checklist, some of the things that you want to be looking for, T4, so this is a Wales tracheist checklist, simple things that you can do when you're looking after a patient with a tracheostomy. So check your tapes and your dressings are in place. They're not too tight around the patient's neck. You're able to pass at least 2 finger breadths behind your strap. Check for any red flags. Is the tube blocked? Is there crusts in there? Can the patient breathe? Are they desaturating? Those are signs that trigger the nurses to call you. And if you're called to a patient with a tracheostomy tube that is blocked, you need to take the inner tube out, clean out the crust, and put it back in. If they still can't breathe, that trachea tube needs to come out. There's a hole there already, because patients can die if you don't move quickly. So always know what the red flag signs are. You want to look at the inner tube as I talked, so it's regularly cleaned, so it doesn't crust up. You want to look at the cough pressure. If you've used a cough trachea tube, 20 to 25 centimeters of water is fine, or you could use the actual pressure gauge that we have in our hospital, a manometer. H for humidification. This is very important. This is why it crossed up. So make sure you have humidified oxygen going down the tracheostomy tube. Make sure that it's the appropriate one for the patient. You're not putting too much high flow oxygen through that. And in emergency management, we often have a sign over the bedside so we know the patient has a front of neck airway, whether it's a tracheostomy or laryngectomy. So when you walk into their room, you know exactly what sort of airway they have. Particularly in an emergency, do not put, bag a mask on someone's face if they breathe front of neck. It's no good, particularly in a laryngectomy. Suction is very critical. The nurses regularly will suction. We teach our patients also to suction to get rid of secretions. And this just shows you sort of changing a tracheostomy tube. So when you change it, always have your tube sets on the bedside, a smaller size one set. You have your suction ready to get rid of any clots or secretions. The neck is slightly extended, and you take it out, you put the pressure back up, and you secure it. I'm going to talk a little bit about cricothyroidotomy. Not that you're really going to do this. It's not very often that you come across a situation where, A, they can't intubate at all, and B, you don't have any kind of access. But if you're ever in a situation where there is no access, then a cricothyroidotomy is certainly something you can think about. So I'll talk about the anatomy. So your thyroid cartilage, the most prominent bit is the Adam's apple, the laryngeal prominence of the thyroid cartilage. So you can feel that. You need to just run your finger down the Adam's apple right to the end of it. It just slides down on that anterior lamina, and you come onto the cricoid, which is like a ring. So in between your cricoid and your thyroid cartilage, you've got your cricothyroid membrane. That's where you're aiming for. And similar sort of, so this is the sort of anatomy. So you can see your cricothyroid membrane in the midline there. That's what you're sort of aiming for. And that's the point that you want to try and put a tube in. So same sort of steps. The patient is set up, local anesthetic. You make your incision, infiltrate with some local anesthetic. You can draw up your landmarks as shown, infiltrate, and then you put in your, so this is what you need to do. You might need a spreader because it's harder because the cricoid is a ring. It doesn't give as easily as you would if it was tracheal rings. And you want to put your thyroid cartilage, you want to put your tube in. Often it's a small tube that you will get, so the time that a patient can be on a cricothyroid intervention is not as long as if you had a proper tracheostomy in place. So you will still need a definitive airway after you've done this a lot later. So that's the anatomy as shown and where you need to be. And the same sort of steps, local anesthetic, incision, dilate the cricothyroid membrane, carefully put your tube in place with a curve on it so you don't end up with posterior laryngeal injury, which has happened, and secure it. Now, this is a sort of, anatomy of it that you might see. Sometimes you might need to guide your tube in with a bougie. Sometimes you could do this, you could do a tracheostomy percutaneously with an endoscope, but often with cricothyroidotomy, that means you don't have time. So you just want to get the airway down as quickly as possible. I've put this picture up just to say that the whole aim of securing an airway is to try and save the patient's life and to make sure that that person is there for their next birthday and their granddaughter's birthday and their convocations and all of that. So whatever you do, it's about the patient. Do your absolute best to secure the airway in an emergency or not an emergency, and just think about the person behind all of that and the critical steps. So I think I'm just going to stop here, and thank you for your attention.
Thank you so much, Dr. Oladejo. That was a very stimulating lecture. And I'm wondering why it was when you were presenting that so many things had to happen, but I think we understand. Maybe we need some cricothyroidectomy or something.
No, thank you.
Thank you so much. We are coming to a close with the first, with the symposium actually, before we move into the skills demonstration. But prior to that, we're going to have a meeting with the GSAP scholars very quickly, immediately after this. But I would like to introduce a very special guest here, former Chief Medical Director of the University College Hospital, Professor Temitope Alunga. Let's give him a round of applause. On our schedule here, he's supposed to help direct the skill stations in coordination with Dr. Jifini, but I just wanted to say something before we go into that session. We just want a word from him. Dr. Jifini, the mannequins are going to come in. Immediately we address the GSAP scholars, but I just want Prof to say something in recognition of his expertise in this field. Please, he's an orthopedic surgeon. I forgot to mention that. And the last comment, he was also my teacher in medical school, or our teacher. Nice meeting you, sir.
Thank you very much. I welcome all my colleagues, Professor Ekialagunju, Professor Adaize. I welcome all my colleagues from England who have taken time to come. And most especially, I welcome Professor Oladejo. I'm sure you don't know why, but those of you who want to know should know. We happen to have a common, something that binds us together, and that is Leicester. So, please put. Okay, about Prof. Well, they said I should say something about him. I said I have a relationship with everyone here, all my friends from England and the IMSG team. I want to welcome you. I said, but Professor Ladejo, more importantly, because we share a common shire. So you have Leicestershire, Wolverhamptonshire, you have all kinds of shire. And so when I read about him and the robotic surgery, I said it had to be him. And it had to be an Ibadan product. So congratulations. And I'm very proud of you. We're very proud of you. You're welcome. In 1990, when we got to England under the Overseas Doctors Training Scheme, the consultants were struggling to undertake the ATLS course. As an orthopedic surgeon, we've benefited from two things. Orthopedic surgeons benefit from war and disasters. When there is a war, the outcome of the war, bad or good, the orthopedic surgeon has something to take away. So it was the unfortunate incident of an orthopedic surgeon whose airplane crashed in the cornfield of Nebraska in the United States that gave birth to the ATLS. And so in 1987, 88, it was, the top talk of the town. But it didn't get to England until about 89, 90. And at that time, we were not allowed as SHO registrars to enroll for the ATLS because our consultants in England have a clue what the Americans were talking about. So in 1992, those of us who were privileged began to attend the ATLS course. And when we finished, we did the basic AO course, and then I had to go to Switzerland, Davos, for the advanced course. But when I got back to Nigeria in 95, I tried to get people to do the ATLS course, and lo and behold, they said you have to pay about $2,000 because it was a franchise, and they were not going to bring it to Nigeria. And then somehow somebody was able to get a franchise in Port Harcourt. But before then, I sat back to take a decision on what else can you do that is local to try and circumvent the preventable deaths that were staring at me. And so I wrote a book called Basic Trauma Care Course. Basic Trauma Care was a conglomerate of submissions from most surgeons, including oral maxillofacial surgery. But instead of having a full-fledged ATLS pattern, It was more like an algorithm. And so if this happens, what do you do? So you have both the theoretical part, and then you have some schematic figures, just like what Professor Leiter just said. You do this, next step you do this, next step you do this, next step you do this. So there were theories. And then when I introduced the Cambridge Color Code of identifying trauma cases, everything looked pretty strange. I couldn't get cervical collars. There were no cervical collars here. And one day I was walking and I saw somebody with the bathroom slippers. And I picked it and I configured it into a collar. And so for almost 10 years in the emergency department of UCH, we used to buy a box, a carton full of size 12 and size 10 rubber slippers. And so we used them as cervical collar. It was called a longer collar for want of nothing to call it. But then it was one way by which we were able to circumvent the issue of getting proper collars. As if that was not enough, to do the basic trauma care course, we had to go a little bit more native. I come from Ondo State. People eat asun, and they also take, some meat in Ondo. I'm not going to mention the name. And so what I did was to go ahead and we went to the abattoir, and Professor Ladojo was not there. I said, please, what I want you to do is just to decapitate the animal, cut there from very close to the head, leave the neck, leave the trachea for us, and when you are trying to, dissect and sell, preserve the diaphragm. So now I had a stump of half goat, which has been well skinned, and then we use those ones for CTTD. We use that for the practicals for chest tube insertion, and we use the trachea that was preserved for cricothyroidotomy and tracheostomy. But after we've done all of this, because everything we used was clean, we then sacrificed the stuff for ASU in the night. So every time I organized the course, people were looking forward to the goats because it was half. And every time we did the practical sessions, we had to check if you do your chest tube, we have to now look underneath to be sure the tube did not perforate the diaphragm of the animal. It was a lot of fun, but that's the best, that was the closest we could get in arranging this course. So you have come at a time when things had become a little bit difficult. So today, on behalf of the emergency department of University College Hospital, to which Dr. Ojifini and his friend spearheaded, going to South Africa to undertake the training. I want to thank the IMSG for coming. Please give them a round of applause. What you've received, or what things you are going to receive, will have cost you $2,000, maybe a little bit more. To actually, I'm not joking. This course is a 2-day course. It used to be two days or thereabout. And it was $2,000. I remember my late professor, what's his name now? The professor of cardiothoracic, Adebo, had to go to the United States, and he paid $2,000 for an ATLS course that I did in England, technically free of charge because I was a trainee. And so you people are so privileged today. And now comes the practical sessions. And I want to believe that you're going to learn a lot. But let me warn you that when these courses began in 2003, the basic trauma care course, the nurses came first. Why? Because they were very diligent. The nurses in the emergency room came first. They beat all the doctors to it. Why? Because all the role play that we did, having the plaster room technicians, come in, pretend as if they had an injury, and we had multiple injured patients on the floor, and the nurses would come and say, this one is not talking. This one has problem. This one has shouting, put this one aside. And they were using the Cambridge color code, red, yellow, and they were able to, because they've been training and been doing it, but they didn't know what they were doing, but they were able to apply what they did, what they knew with now these practical sessions, and they did excellently well. So I made sure they had a bigger share of the goods when we finished all the training. So, ladies and gentlemen, I've been asked to say hello, and I've said hello for too long. But most importantly is that you couldn't have asked for a better time to get this. Now that we have too many jackbars, people are going out of the country in drones. these men and women have come back to give to this wonderful institution. I'm sure they will have checked the seats where they were sitting when they were medical students. And you know, some of them were very nice. They would sit close to the lecturers. Some of them were very tough, like Super K. They would go and hide somewhere so that they wouldn't be identified. But it's now a military man, so I'll be careful what I say. I'm sure Oladejo were quiet people that will listen to the lectures. But those of us who were rascals will sit down to look at the lecturer's face to try and intimidate the lecturers. But whatever it is, this is the best place to school, and I'm sure that you have the best brains coming back to give back to the institution. So I want to thank you. I thank you.
Thank you so much, Professor Temitope Alonge. This is my teacher here, and it's a real honor to be here and to see you again. I finished in 2002. Oh, here we go. That was 23 years ago. And I just want to say a big thank you for, driving and setting up innovation and training. The basic surgical care course, I was on that course. So that was one of the very first surgical courses that I attended, and that was 23 years ago. So thank you so much for continuing to strengthening medical education, for supporting the development of healthcare in UCH in Nigeria, trauma, leading even rapid response for mass injuries and things. We really appreciate you. And I think, yeah, please, round of applause. And I will say that it's important that you recognize that this is a continuum. I'm still with my teacher. I'm here giving back. You need to pay it forward as well for the next generation. And there's something about inspiration. When we used to walk these hallowed halls of fame, I remember well, Prof. Alonge, Mr. Oluolu Akute, our current provost, Prof. Ogundiran, who they were, teaching surgery, orthopedics. They were the, fellows of the Royal College of Surgeons of England. And we looked up to them, and I felt, I'd like to be like these guys one day. Never mind that when Mr. Akute is coming on one side of the corridor, I take the other side of the corridor. It was in his nice bow tie. It was power. So for inspiration's sake, I think it's important that, we have mentors and people you look up to. And I just really want to say thank you to you and all the faculty that have held it together. Thank you, sir. So we're going to come to the section where we actually go towards the practical skill stations. So we're going to need a little bit of prep time to bring the mannequins into the room. So you can stretch your legs if you want, but we're going to stretch legs? Yeah. You can just have a quick break whilst we get the mannequins ready, get the stations ready for you. We want all of you to participate, so try not to leave without doing CPR or intubation or something. I'm going to invite the IMSG to please come forward because we're going to have a little session together with the media. Just want to say a quick hello to you. Channels TV are here currently recording. And if I could invite all the GSAP scholars to please come here in front so we can have a meeting with you as well. So we've got about a few minutes of prep time to prepare for the practical skill stations, meet with the GSAP scholars, and then we can start the afternoon session. Thank you so much. So IMSG scholars.
IMSG scholars.
Oh. Can I get the IMSG members to please come forward, please? Because I think the scholars have something to give us. I'm assuming, I don't know. IMSG scholars. Oh, wow, okay. It's getting real now. Yeah, time for resuscitation. IMSG scholars. IMSG members, where are we? Yes, yes, please come on the stage. IMSG members, can we please come forward? Give us a second. There we go. So if we can have the IMSG, please, let's come to the center. Let's come to the center here. Yeah, so that there's enough space. Yeah. How do we do this? I think there's about to be a presentation. I can see our IMSG scholars unwrapping Christmas presents early. I'm not sure. A bottle. Our president. How do we do this? A curve. A curve so that we're. Oh, wow. Okay. So we've got our IMSG scholars here. So we're going to take some pictures. Sorry, please, can you help me with my phone? Have we got all the GSAP? Is Dr. Adebayo still here, or Prof. Adeshino? GSAP, okay. I think this is a really lovely moment with our scholars. Yeah, thank you so much. Yeah, so I think there's a presentation. Okay.
Good day, everyone. So, on behalf of the Imsg-Uk scholars, we want to present this gift as a token of our appreciation to our donors for their continuous support towards our education. So you can see their magnanimous hands holding on to our hands and trying to help us and to drag us up to success. So we say thank you so much for your support, and we are grateful to you. Thank you, sirs, and thank you, ma'am. Is an award of gratitude and excellence in educational philanthropy, and still presented to our supporters. Thank you so much, sir.
On behalf of Ibadan Medical Specialists Group, United Kingdom, we thank the scholars for this wonderful gesture and presentation. This painting is really admirable. We're so proud of you. We're so proud of your achievements. And we want to thank you for always sending us really inspiring letters of appreciation. I find it very uplifting when I receive joyful news that you guys are making very good progress with your studies and receiving distinction awards and graduating as doctors. We're so proud of you. Thank you so much. And thank you so much for this. This is a wonderful, incredible gesture of appreciation. Thank you.
Thank you so much, our scholars. So we'll take one final picture with our scholars before we... Dr. Shikalu, please do not go. Thank you so much. Very, very, very kind. Thank you. Oh, I think there's one more. Hold your pose. One final. Tuck your tummy in. Smile. Thank you so much. That was lovely. Round of applause for our scholars. I'm going to ask. So we're going to continue with the setup. I can see, the team are ready with the mannequin. So we'll carry on with the setup. This session will be moderated by Prof. Temitope Alonge, who is the director for the skill stations this afternoon, ably supported by Dr. Kehinde Ojifini, who's the consultant. He's the lead for emergency medicine here in UCH Ibadan. We've been closely collaborating with them. So we'll be doing cardiopulmonary resuscitation. We're going to start with advanced trauma life support, how to resuscitate in an emergency in trauma. And then we'll talk about pediatric shock, cardiac rhythms, and a whole lot of everything else in between. Whilst we do that, the IMSG need to have a quick picture. What do you want? Yeah. Can I invite Dr. Kehinde Ojifini, please? Oh, you're there. Please, a round of applause for him.
Thank you and good afternoon. I understand it's quite sunny and your attention span may start reducing. So we'll try to make it quite interactive. I will make it short and straight to the point. If you look on my right side here, you see some doctors in blue and some of them in wine, yeah, okay, wine color. They are the emergency medicine residents, and they're going to be first doing the role play. The role play is about a patient that we use the ATLS protocol for, so that you can understand when we talk about A, B, C, D, E components. After the role play, we'll now get into the practical sessions where some of you, a number of you are going to be involved in hands-on in terms of the CPR, and then we do the airway stations, and after that, we'll do the pediatrics. We want to make them short and straight to the point so that we can leave here in time, okay? So we have just one mic, so you need to be extra quiet so that they can hear us. The registrars will try to speak as loud as they can so that you would all hear them. But let's keep it quiet. Thank you.
Hi guys, good afternoon. So I just got a call from Bere about an accident, and there's this guy that we're supposed to pick up. So I was told that he was involved in an accident. He's a middle-aged man, So, Dr. A, can you assess this patient? Let's know what we have. Does he have a pulse? Okay, so he's unresponsive. He has a pulse, but he's unresponsive. Okay. So can we put a neck collar in, Dr. B? Put in a neck collar, please. Yes. Stabilize the neck. So maintain. All right.
Okay. Okay, thank you very much. What's your estimated time of arrival? Okay, thank you. We'll be expecting you. Okay, so I'll get my team. I just got a call from the EMS that a patient is coming in. So I'll get my team. We'll be resuscitating these patients using the Advanced Trauma Life principles. That's the ATLS principle. So doctors A, B, C, D, and E. And then we'll be getting, as part of our preparation, we'll get our couch ready for these patients.
Guys, please, let's move. Let's
Team,
move.
please. Let's come together. So we are expecting a middle-aged man, victim of motor vehicle crash with head injury and suspected thoracoabdominal and extremity injuries. So please, let's put on our PPEs as we await the patients. Okay, so let's put on our PPEs. Patient is here. Okay, so good afternoon. I got a call earlier from you. I'd like to know if there's an update concerning the patient. Okay, so as part of attending to a patient, you have to put on your PPEs, our nylon aprons, your face mask, and your gloves to attend to the patient. And then,
all right, so
I have members of my team here.
So we have this young man. We found this young man unresponsive, victim of a road traffic accident. His SAT was low, 75% in room air. We were able to put him in a cervical collar. We've commenced oxygen with nasal prongs at 4 liters. And we believe he has some other injuries and will benefit from your expert care.
Thank you so much. Yeah. So I'll be introducing you to members of the team. They will tell us what they stand for and what they are doing. So Dr. A.
Thank you. My name is Dr. A. I'm in charge of the airway. So my role is to assess the airway, ensure it is patent, identify any problems, and if need be, to take action appropriately. I have with me my equipment for airway to secure airway, my adjunct, and if need be, if I have to put a definitive airway, I have everything ready on ground.
So Dr. B, please.
Hello, my name is Dr. B. I'm in charge of breathing and ventilation control. I'll be basically doing everything that has to do with breathing for these patients. If patient needs to have a chest tube in, I'll be the one that will put it in. Thank you.
I'm Dr. C. I'm in charge of circulation and bleeding control. What I will ensure is that I will ensure this patient does not have circulatory compromise, and also I also want to look at the extent of the bleeding and also to identify the other bleeding sites in this patient.
Dr. D, for disability and neurological deficit. So I'll be using the Glasgow-Coma scale and pupillary response to check for neurological deficit. I'll also be checking his blood sugar.
I am Dr. A. Mine is to ensure to expose the patient to know if there will be other injury that we did not pick, and at the same time to look at the environment for safety, because there may be blood spill or fluid spill that could become a hazard. Thank you.
Thank you, team, for giving a rundown of what you're going to do. Summarily, we had a patient, a polytraumatized patient, coming from pre-hospital. So the patient was assessed pre-hospital, a triage was done, the patient is in the hospital now. So we'll take our primary survey, and then we'll have primary survey adjoined quickly. So while we have a patient in the hospital, the first thing we'll do is to connect to monitors so that we can get the parameters of this patient. Do we have the monitor? So we're connecting the patient to multi-parameter monitor, the blood pressure, the temperature, pulse, saturation. That's what we're doing now. And then we'll go around the ABCD of resuscitation as we'll have it. So Dr. A, over to you.
So right now on entry, the patient is connected to a nasal cannula, but I have to remove that because the patient has to be on high flow oxygen. So I'm removing that right now. I'm placing, thank you. So I'm placing a non-rebreather face mask patient right now to be able to supply the patient with high flow oxygen at 15 liters per minute.
Okay, so I'll be reading out the vitals we have on the monitor. Patient is tachycardic with a heart rate of 128 per minute. His hypotensive BP is 68/46 millimeters of mercury. On changing the nasal prongs to a non-rebreather face mask, patient is saturating at 98%. And then is also tachypneic with a respiratory rate of 35 cycles. So Dr. B, over to you, please.
Thank you. So right now I'm checking the patient's chest. I want to, first of all, listen to the breath sounds of the patient. I'm going with my stethoscope right now. Listen over the lung zones. Okay.
There is absent lung sound. There is absent breath sounds on the left of the patient.
All right. Okay, so there's absent breath sounds on the left side of the patient. I want to percuss quickly to be sure if what we have there is fluid or air.
I need a volunteer. So we have a patient that has absent breath sounds on the left hemithorax, hyperresonant percussion note, and then a low blood pressure. What do we think from the students? Pardon? Is it just pneumothorax? Tension pneumothorax. So what do we do? What is Dr. B going to do? Decompress. With what? Needle decompression. Very important.
Thank you very much. So I'm going to do a needle decompression quickly. Can I get a needle, please? I'm going to the 5th intercostal space on the mid-axillary line. That's what I'm going to do, the needle decompression. Can I get a needle, please?
All right, so Dr. B got a needle in, but we're still looking at the monitor. What is the problem on the monitor right now? Anyone? Okay, the last I saw was that the saturation was 78. It means we'll go back again. We'll start afresh. There is a problem in A that has not been solved. So we'll go back to Dr. A.
So going back to A, I'm going to reassess to check for the airway. So I'm going to be tapping my patient, assuming his name is Mr. John. Mr. John, Mr. John, Mr. John is making gurgling noises, so I have to suction now. I've suctioned, and then I'm also going to try to secure the airway, an oropharyngeal airway. So let's take a look. Our saturation is back up.
Are we doing well?
So Dr. B put in a needle earlier.
The needle is on the right. The needle in the 5th intercostal space, mid-axillary line. That's the same point where if I need to do a chest tube, that's where I'm going to put the chest tube also.
So needle in, I can see a gush of air. So I know that there's a release. Okay. So at the same time, I'm quickly doing a finger thoracotomy. I'm putting, taking a stapel, making an incision. I'm using my finger to open into. Okay. It's not working.
The microphone suddenly stopped working. So what he did initially was to have a needle compression. After I did thoracotomy, at least the pneumothorax. Okay, thank you. And then thereafter, he puts a chest tube in, and that is all he has to do to save this patient. So we've done that. Okay. Dr. D.
So Dr. C, over to you.
What we want to do now is that once the patient comes, we've given the patient 2 wide ball IV access, and now I want to feel for the pulse. The patient is tachycardic, the pulse is feeble, and also you want to check also the capillary refill. This patient has delayed capillary refill.
Capillary refill more than 2 seconds.
All right, so right now I want to put my fluids, sample for cross match, for arterial blood gas and other investigations, which has been done, and I've sent sample to the blood bank. So can anyone call the blood bank for me to inform them that we have a trauma patient that will need transfusion?
Hello, good afternoon. This is Dr. A from Emergency Department. Am I on to the blood bank?
Good afternoon. You are on to the blood bank.
Okay, so I'm calling in respect of one of our patients, a middle-aged man, victim of road traffic crash with head injury and thoracoabdominal and extremity injuries. He would benefit from blood transfusion, so I'm calling to activate a massive transfusion protocol.
It's okay. We have quite enough blood in the blood bank at this time.
Thank you.
All right, so
moving on.
All right, so in circulation also, I want to assess these patients for other bleeding sites. So the first part I want to go to is that I want to check the urethral meatus also before I pass my urethral catheter.
Is there a reason why he's checking the meatus before passing a catheter? Anyone? Okay, we'll check contraindications to urethral catheterization in trauma patient, right? So we'll check that. So once we have blood on the meatus, we want to be extra careful. We're thinking there is urethral injury and you do not want to pass a catheter at that time, okay? Good, so we'll check that up. So let's go on.
All right,
so there's no blood?
No, sir, there's no blood. So I've passed my urethral catheter. Now I also want to check this is called the pelvic compression. So I want to check for the stability of the pelvic. The patient has a stable
pelvis is stable.
Very stable, and also long bone. And now after that, I want to also use called the extended focused assessment of sonography in trauma. That's the EFAST. So the abdomen now.
There is free fluid in the peritoneum.
Okay. All right. So please, can anyone put a call through to neurosurgeons, please? And also, after checking the lungs, I also like to check the heart also for any fluid.
There are no abnormalities on the lungs and then in the heart.
Oh, okay, no problem.
So what injuries have we identified? We had tension pneumothorax, that's what we could remember. The patient is head injured, he's unresponsive. The GCS is not 15. So head injury, tension, and then there is free fluid in the abdomen. It means the patient has blunt abdominal injury too. Are we together? Beautiful. So what other thing do you want to do, Dr. C?
I want to put a call back to blood bank to ask if the blood is ready, and also I want to send for...
Blood is ready. There is a unit of blood ready.
Okay, so I would like to put up the blood. also like to give IV tranexamic acid to this patient.
Can we see the monitor? Yes. So our patient is improving. True or true? Very true. Dr. D.
Yes, I'm Dr. D, and we're going to be assessing for disability and the neurological deficit. So now we're going to use Glasgow scale to check for his neurology. Hello, Mr. John. Okay.
Mr. John responds to voice. So that GCS for verbal is for eye opening. He opens eyes to call. What is that? What number is that? What do we score? Opens eyes to call. 3, beautiful.
So Mr. John is also confused. His speech is confusing.
Okay, confused, verbal. That is a what? A 4. So 3, 4. And then we're moving on to motto.
And Mr. John also localizes pain.
He localizes pain. That is what? 5. So we have 3, 4, 5, making that a 12. So if you have a GCS of 12, moderate head injured. Good.
So we're also going to be checking Mr. Pen touch.
Pupils are fine.
Okay, so the pupils are fine. And we're also going to be checking.
RBG is normal.
Thank you. So move on to Dr. D, Dr. E.
I am Dr. E. My responsibility is to check this patient from head to toe and look at the back to expose the patient in order to identify any occult injury that we did not pick at the initial stage. So I will need my team to help me to log roll the patient.
Good. So how many people do you think we need to log roll this patient? Why are we log rolling? What does it mean to log roll? It means you want to move this patient as a unit so that if there are injuries that are not completed, you don't complete that injury. Specifically the spine, and you want to run through the spine, ensure that the neck is stabilized at all times. C-spine protection is very important. Until you clear that C-spine, you do not mess with that C-spine. So that's what we're going to do. We need a minimum of 3 people, 1 person stationed at the head of the patient, holding the patient, and then the other 2 people with their hand crossed, they move the patient as a unit. And then the 4th person would run through the spine and then finalize with a digital rectal examination to check for the sphincteric tone. Okay? Good. So let's go.
Let's see how they are putting. They are not putting their hands separately. The people are crossing their hands in the just to move the patient as a unit. And then we have a 4th doctor that would examine the C-spine and also do a DRE. So can we move the patient, please? On whose count?
On my count. 3, 2, 1, go.
Through the neck and to see if there's any step deformity or obvious open injury. Now do that up to the waist or sacrum. So from the head, the neck to the sacrum, there's
no step deformity, no obvious injury.
And I'm going to do a digital rectal examination. And why is it important to know if the inner sphincteric tone is intact?
Normal sphincteric tone. Good, beautiful.
So on my count, we go back.
So he's also going to go ahead and remove the dashboard at this point.
Spine board. So in settings where the X-ray machines are mobile and are available, we want to put the boards underneath the patient so that the patient can have the trauma series done, the chest and the pelvis.
So the patient will be rolled back as a unit again.
So team, on my count, we put the patient back on the supine position. So 3, 2, 1, go now.
Can we have our monitors again? Good. At this time, we had identified a lot of injuries and we had called the specialist. We had called general surgery team, neurosurgeons will be there, and then I think orthopedics have no job here at this time. But we'll do our x-rays to check. and then we'll call CTSU. So now, I'd like to mention that we have run through all of this, but I can assure you that in the emergency room, it's not stepwise fashion. We'll follow the ABCDE, but it doesn't have to be finish A, then move to B, then C. You quickly run through these in less than 5 minutes. We do that often. We do it every time. We do it every day. It's our calling. That's what we do. Thank you.
Thank you very much.
Thank you. I hope you learned something. I told you in the morning that we want to make you emergency physicians in 10 minutes. All right, so for those of you who have not been coming to the emergency room, start coming. And you see more of this, and you see some other things that are not even trauma that we do in the emergency room. All those things you watch in Grey's Anatomy, we do them, okay? All right. So we will go straight into the next phase. That's the CPR. We've got the mannequins for the CPR, and unfortunately, not everybody will be able to have hands on. We just want as many people as can put their hands on this to do it so that we can see you demonstrate how to do a quality CPR. So can we get the mannequins up? So we're going to have like 8 stations. We'll put them all here. And we have 3 persons per station per time. So that if once group goes through it in 2 minutes, another group comes in, and within 10 minutes, we want to be able to do at least 72. Don't worry, we'll see how that will go. We'll just make sure that we can do as much of that as possible. And after that, we go straight to the airway. All these things are just to sensitize you. You can come to the skills labs and see many of these things and have a whole day of practicing on them. And you can come to the emergency department in an organized fashion and get to practice and practice and practice. Practice makes perfect. Right, so just give us 2 minutes, and then we'll be set to do that. In the morning, you heard Professor Lagunju tell you so much about the basic life support, and how it is that you have a chain of survival that needs to be followed. If the chain of survival, we said, is as good as the weakest, so we don't want any weak link in this. So we'll have 3 persons to a mannequin, and you have a registrar who is going to lead the team on each mannequin. And within 3 minutes, we want to see what we can do. We want you to practice. We want you to do the chest compression so that we can tell you whether you are doing it right or not. If that is all we can achieve today to make you do the chest compression, that's fine. Then we can go to the skills lab or come to the emergency and do more. Right, are you guys set?
Thank you, sir. So, cardiopulmonary resuscitation would want to take volunteers. Okay, so this is how we're going to go about it. The residents will do one. The resident will start. I want us to show the students how to go about it, and then we'll now monitor them do. So let's have a resident per mannequin first. A resident per mannequin. Are we good? So, okay. So, okay, so very importantly, I want us to take this acronym with us. Doctors ABC. DRS ABC. When you're doing resuscitation for a patient, whether in hospital or out of hospital, you have to be wary of danger. You have to be safe to save a life. So the first thing is D, danger. So you assess for scene safety. And then after that time, so Dr. Agwin is assessing for scene safety. Beautiful. So you do not want to do a CPR on an express, for instance. Somebody was electrocuted. You will not start CPR there. You want to be safe. So that's scene safety. Then we'll move to response. R for response, DR. So you want to be very sure, pretty sure that this patient needs a CPR.
Mr. A, are you okay? Are you all right?
He's not responsive. So you know that there's a problem. So what do you do next, ma?
I'll get some, okay, so I'll shout for help. Help, somebody help.
That's the S, DRS, doctor. So she has sought help, and then the next thing she wants to do is she wants to reassess the patient. ABC, that's the last one. So she's doing that.
So I'm checking for pulse. I'll be checking the carotid pulse, and then I'll check if there's any chest rise, if this patient is breathing, and I'll do this in less than 10 seconds.
Thank you, Dr. Agun. So she has checked, she has assessed again, no pulses, and the patient is not breathing. It means the patient needs what? Cardiopulmonary resuscitation, okay? So the next thing she wants to do quickly is to quickly activate emergency response and call for AED. In the hospital, you want to call for defibrillator. We have that in UCH. A round of applause. So now,
system and get me the AED.
So after doing that, we know that this patient needs a CPR. So how do we do a CPR? Dr. Agwin is going to interlock her fingers this way, and then she goes straight on the chest, the midline, just in between the nipple line for males. For females, just check for the midline at the sternum, and then her hands are interlocked, and then she has her elbows locked too, fixed this way. And then she goes from the back to do a chest compression. So she pushes hard and fast. What is the rate? She will do 100 to 120 in a minute. It means approximately she's doing about 2 compressions in 1 second. And then what is the ratio? You know, she's doing cardio and pulmonary. So you have 30 chest compressions to 2 breaths in an adult. 2 rescuers or 1 rescuer adult. You do 30 to 2. That means she does 30 compressions, and then somebody giving breath to give 2 breaths. Okay? So that's how we'll go. She pushes hard and fast, and she allows for recoil. She doesn't press and hold there. She allows for recoil. She goes back again. So let's go, Dr. Agun. Who is assisting Dr. Agun with the airway? Dr. Aove. Please come round. Let's quickly do this. So Dr. Agun is going to do chest compressions, and Dr. Aove is going to
1, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
25, 26, 27, 28, 29, 30. We can see the chest rise. What did she do initially? She did LT chin lift just to open the airway, and then she put the marks. In an out-of-hospital setting, what happens? You have your pocket marks, or you do mouth-to-mouth breathing. So let's have what the resident do. So can we all do at the same time? So on the count of 3. Dr. Oche, where are you? Okay, you're there. No, just stay there. So can we have everyone together? Dr. Latimer, so let's have everyone together.
Hello, we want to see you do the chest compression. Registrars, let them get on the mannequins and do the chest compression now. Right, tell them how to lock their hands, how to position themselves, and start this chest compression. I'm going to give you the rate. I'm going to give you the rate at which you're going to go. So you're going to do 30 compressions. Are we all set to go? Everybody set? Okay, the first set. Everybody ready? Chest compression. Position your hands for chest compression. Are we all ready? Are we all ready for the chest compression? On my count, 3, 2, 1, go! 2, 3, 4.
Try to listen to the metronome to direct you on how to go about your chest compressions.
All right, stop. We're going to start again. We're going to start again. Still stay where you are. Stay where you are. On my count, 3. Once I say 1, go. You start the chest compression and you listen to the rhythm that is coming from here. Can you hear that? That's how your chest compression is going to go, in that rhythm. Are we ready? 3, 2, 1, go! Lock your elbows. Stay closer to the patient. Turn, 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 turn. Stop. Okay, for the last time, we're going to do it. Now you will count out loud by yourself from 1 to 30. Are we ready to go? 3, 2, 1, go. 1, 2, 3. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Can we have the next set? Let's clap for them. All right, that's just for you to have a taste. So you know there is still a lot for you to do in terms of getting your rhythm, in terms of getting how fast you should go, and getting the depth of your chest compression. Next set, just for chest compression, chest compression, just chest compression. Are you ready to go? 3, 2, 1, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Make sure your elbow is locked. You are going to do it again, so that when next you come to the emergency room, you know we are not joking. Are we ready to go? 3, 2, 1, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11,
12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Well done. Let's clap for them. The third set now. The third set. If you have a witnessed arrest, your patient must come back to life. 9 out of every 10 witness arrests in the emergency department here comes back to life. Right. So, if you have a witness arrest, your patient must wake up. He may not be able to say, thank you for saving me, but he must have return of spontaneous circulation. Are we ready to go? Ready? 3, 2, 1, start. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 23, 24, 25, 26, 27, 28, 29, 30. How many of you are sweating? Get ready to go again for the second time. Are we ready to go? Get ready to go. Get ready to go. Position yourself very well. Residents, make sure that they are well positioned. On my count, 3, 2, 1, go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29. Excellent. Clap for this group. Well done. Then the third group, third set. All right, well done. Let's clap for them. Want more? Go to the skills lab. Come to the emergency department. Thank you very much.
So quickly, we'll move to airway management, and then we'll just run through that. We will not take time on that, really. So airway mannequins, please. These are very basic things we should be able to do. You don't have to be a doctor or a nurse or healthcare worker to be able to deliver basic life support, whether out of hospital or in hospital. It has been shown to save lives and improve chance of survival in a lot of victims. So we pick volunteers now, but please would appreciate if those that came up earlier are not the set of people that will come up again this time. Let's share the joy. All right, quickly. So how we're going to go about it is I'll run through what they have to do so that other people on the other side of the podium would be able to get what they are going to do. So basically, it's airway management. And then we'll start from assessing the airway of the patient. Now, how do you assess airway in a patient? You don't need any highfalutin thing to assess the airway of a patient. What you need to do is to speak to that patient. Once the patient responds to you, it means the airway is patent. Patient responds, airway is patent. So that's the first thing. You want to assess the airway, you want to speak to the patient. Hello, Mr. A. Mr. A, are you okay? And the patient is talking to you. So most likely the airway is what? Is patent. And then quickly, you move on. If the airway is not patent, or you connected the patient to a monitor, and then you see that saturation is not so good, you want to ensure that that airway is patent enough to deliver oxygen to every part of the body. Then you want to quickly talk about positioning of the patient. You want to put the patient whether in left lateral position so that the tongue that's probably had fallen back from a loss of consciousness state will return back. So that's what you do. You want to quickly position the patient, and then again you want to, okay, so now I've spoken to the patient is not responding, then positioning quickly. So in recovery position, left lateral position, and then I want to monitor, I want to check again. So if I don't have, if the saturation is still very poor, the next thing I want to do is to do airway maneuver in this patient. So I want to do air teaching lift most of the times if it's not a trauma patient. But for trauma patient, what do we do? Jaw thrust. Why are we not doing air teaching lift in a trauma patient? Because you suspect a C-spine injury and you do not want to cause more havoc. So immediately after doing that, you want to check again. If there is no improvement, then you move on to airway adjuncts quickly. What are the airway adjuncts we are familiar with? Airway adjuncts we're familiar with. We're not talking. Oropharyngeal airway and then nasopharyngeal airway. Have we seen one before? I'm sure we've seen one before. So quickly, the nasopharyngeal and the oropharyngeal airway would measure to ensure that it's the right size. I've seen a patient swallow oropharyngeal airway before, a small size. Yes. So it's possible. You need to measure to be sure, starting from the angle of the mouth to the tragus. So that's where you want to measure to be able to put in the right adjunct for the patient. And then you have done that, and the patient is still not responsive. You want to sanction, very importantly, and then we'll sanction. We need to go check the contraindications to nasopharyngeal airway. So we want to sanction the patient. Any improvement you want to check. So if there are no improvement, then you want to move on to supraglottic airway in this patient. What are the supraglottic airway? The common one we know. Laryngeal max airway, LMA. Is it here? Beautiful. So that's the next thing. You go in that fashion, and then if that is also not helping that patient, you want to consider a definitive airway. And by definitive airway, you are going directly into the trachea, and then where's our endotracheal tube? So there are instances where you're unable to intubate a patient and you're unable to ventilate that patient. You want to quickly go through the surgical airway. You can do a cricothyroidotomy or a tracheostomy at the very least. So those are the ways you go through it. My colleagues are going to put you through all of this quickly. We will not be doing intubation because we do not have time for that. And it's basic. We just want to do the basic airway. We'll stop at the maneuvers and then the adjuncts, really. So can we go now? So what she's trying to do is to put an endotracheal tube for this patient. I'm sure this particular session will stimulate us to go back and check a lot of things. You need to learn your sizes, and then what you do to a tube, the difference between a curved and an uncurved Hendrickse tube, and all other devices that you may find around. You can see the lungs inflating, and then it looks equal on both sides. There are things you do to check to confirm if the airway, the patient's airway has been intubated. So we'll not go through that, but that's what we have. So can we go now? Now then we can. Patient, and the patient.
For the rest of us who are watching, we're talking about airway. First, we said do the simple things first. The simple things such as speaking to your patient. If your patient responds, it means the airway is patent. That's one way to open the airway. If that doesn't work, you can put the patient on the side so that the tongue can fall away from the posterior pharynx. If that doesn't work, you can use some maneuvers, which include chin lift, L-teeth chin lift, or jaw thrust, as the case may be. You can't do that maneuver forever, so you may want to put something there to
leave the airway open. And that's where your adjunct, the oropharyngeal and the nasopharyngeal comes in. For those of us who are here, make sure you learn to use the oropharyngeal airway and the nasopharyngeal airway. It's more important than even getting to intubate a patient. You may not be able to intubate a patient, but you may still be able to open the airway. Intubation is not the first thing. So make sure you are putting the airway. I want to see people putting the oropharyngeal airway and the nasopharyngeal airway for patients. The hallmark of getting the airway open and breathing for the patient is when you bag and the chest, the lungs expand. So when you have the rising of the chest, it speaks to the fact that you've been able to successfully open the patient's airway and shift air into the lungs. That's what you want to ensure. Right. If any of these ones don't work, then you can go to the advanced airway. The advanced airway can be supraglottic device, such as your laryngeal mask airway. And you can also have the definitive airway, which is the intubation, the endotracheal intubation. Time will not permit us to do that now. I don't want you to think about endotracheal intubation for now. I want you to think about the basic airway maneuvers and the adjuncts. If you can do the maneuvers, I can do the adjuncts, you will save 7 to 8 out of every 10 patients that have airway issues. In the meantime, while they are waiting for the advanced airway management. Thank you. Also, I want to say that you are welcome to come in groups to the emergency department. Just schedule a time with the residents. They will put you through and you will learn how to do this. In fact, you may get to do it on a real patient, because every other day we'd have 1 or 2 patients that will be in need of airway or breathing apparatus. So when you have done this over and over again, would allow you to actually join in resuscitation of a patient and doing airway procedures. Thank you. All right, we have just about 10 minutes to complete this session. 10 minutes, in 10 minutes time, we'll be done with this session. And then we will hand over for the other sessions. Thank you very much for your patience. And thank you very much for your participation. Feel free to reach out to us in groups of not more than 10 so that you can get exposure to doing these things on real patients and also practice more and more on mannequins. We have a small simulation room in the emergency department where you can do that. Thank you.
Can we take our seats now? A round of applause for them. All right, so we've come to the end of the 2 sessions, or 3. And then I bet you those that were out here had learned one thing or the other. And I'm sure they're going to replicate these on real patients. I'm sure they will do well. I'll hand over to our consultant to do a wrap-up of all of our sessions, and then we'll have it. Thank you.
All right, thank you very much, and thanks for your patience and attention. I hope you've learned something, right? Like I said, come over to the emergency department, come to the skills lab, and you'll learn more. All right, thank you very much. A round of applause for our volunteers. Thank you, thank you. All right, we can do more in the emergency department. Let's pack up now.
Oh, good evening. How are you? Okay, good. Good evening, ladies and gentlemen. Hello, can I have your attention, please? In the morning, we had the lecture on pediatric shock. This afternoon, we're going to go through some simulated cases in shock. But before we start, I'd like to set the tone by sharing with you how we want you to assess the patient in a critical situation. So the first set of scenario is just to demonstrate to you how to assess a critically ill child. So here we have a 3-year-old with an unexplained fever and tachycardia. The question is, how would you approach this patient? Show you a few things before we go to the actual scenario. What you see there is the so-called systematic approach to patient care. Number one is, if your patient is unconscious, you will do the BLS assessment. The BLS assessment is just whether the patient is whether the patient is breathing, whether the patient has a pulse. If all that is no, no, and no, you start CPR right away, just as I have seen you practice this afternoon. However, if the patient is conscious but sick, you will do your initial assessment, followed by primary assessment, followed by secondary assessment. In critical care, we do that so that we don't miss anything out. Initial assessment, primary assessment, secondary assessment. The initial assessment is to us what the primary survey is to surgeons. During your initial assessment, that is the time you will take care of any potentially life-threatening condition that the patient might be presenting with. So for the well, it's saying my connection is lost, but I will just continue for now. For the initial assessment, what we do is the so-called pediatric assessment triangle, and there are 3 sides to that triangle. The first side is the appearance of the patient. What does the patient look like? Is he tired? Is he toxic looking? Is he lethargic? So one side of the triangle is A for appearance. The second side is B, work of breathing. And work of breathing, you want to look at rate and effort and presence or absence of abnormal sound. And C, of course, is circulation to the skin. Is the skin mottled? Is the cap refilled prolonged? Is the skin cool? Is the skin warm? So A, B, and C is your initial assessment. What do I mean by that? Your initial assessment is when you walk inside the room, even before you touch the patient. You are not obtaining history. This is very important because in emergency medicine critical care, if a patient is dying, you cannot say, Mamamba Olubere. You have to quench the fire first. So that's why initial assessment is important. After you do your initial assessment, then you can do the primary survey. The primary survey is airway, breathing, circulation, disability, everything that has been discussed of. It is only when the patient is stable. That is when you go back and take history. I have spent this much time to explain this because that is the way I want you to approach all the cases that we're going to discuss this afternoon. Summary, initial assessment, walking into the room as an experienced clinician, what does the patient look like? B, primary assessment. C, secondary assessment, and you take your decision. For us, the history is not like what you do in clinic. The history in emergency medicine critical care is open-ended, which means after you stabilize the patient, you can now go back and be getting more history. That is when you can conveniently say, Mama Kilode, Imba Olubere, not when the child or the adult person is dying. So with that said, let's move on. This is a 3-month-old baby with a history of irritability, poor feeding, and restlessness, according to mom. Any volunteers? What do you think is going on here? Anybody? Where are the residents, emergency medicine resident? So everybody here is medical student? Huh? All right, I'm not going to put you on the spot. What you are seeing here is what we call supraventricular tachycardia, and is fairly a common abnormal rhythm in children. So you can see, how do you know it's supraventricular? I'm not going to go into that details. You are not residents. But the heart rate is 222. It is not possible for the highest you can go as a child is 190, 200. And also, it should just be 222 no matter what you do. Unlike a child who is in sinus tachycardia, it's 180 now, the next minute is 190. So this is a SVT. But is the patient stable? Anybody? He's only 3 months old. Is the patient stable? You are shaking your head. What does that mean? Well, for this rhythm, if the patient maintains a normal blood pressure, we are calling it a stable SVT. So for now, this child who is 3 months, 70/44, I will call him hemodynamically stable, but I will still treat that. The treatment for this is adenosine or do a vagal maneuver, ice on the face, etc. But this same child did this. Have you seen a change in the blood pressure? So this kid now has systolic pressure about 50. The skin color has changed. It's now very mottled. So now it's in shock. It's in cardiogenic shock because of an abnormal rhythm. What is the treatment of choice in this case? This is one instance where you have to do electrical cardioversion. Electrical cardioversion. And that means you have to shock this child to bring him back to sinus rhythm. Before you do that, you are getting your cot, you are getting everything ready. You can give adenosine, but ultimately the treatment here is electrical cardioversion. I just wish our emergency room residents are here with us. So let's see. These patients back to sinus rhythm. You can see what we are doing now is a synchronized cardioversion. You sync, and then you shock the patient. Press that. Goes back into sinus rhythm, and of course, with that, you can see his blood pressure comes back up. So the lesson for this is that cardiogenic shock does not have to be a myocarditis or any infection. It could be an abnormal rhythm. And a common one in a pediatric age group. I think we are disconnected again. The common one in a pediatric age group is the SVT. So let's So here we have a 7-month-old with vomiting, diarrhea, and irritability for the past 3 days. He now appears very weak and listless. Of course, you can see he's 7 months old, is in sinus tachycardia. And then by the time you saw him in the emergency room, this is what he's doing. It's even more tachycardic now. I just want somebody in the audience to guess what this could be from our discussion this morning on shock. It was having diarrhea and vomiting, has not been eating well, has fever, yes, hypovolemic shock. And the treatment of choice here is what? Fluid. So you give fluid. This is after you've given about 20 cc's per kilo of fluid. Has he gotten any better? No. You reassess again and repeat your fluid. Remember what we talked about, that when you are giving fluid in excess of 40 per kilo, you are not giving the 40 per kilo at once. You are giving it in aliquots. 10 per kilo, 10 per kilo, or 20 per kilo, 20 per kilo. By the time you've given up to 40 per kilo, you should assess the patient for fluid overload. Why? Because if, for any reason, if that patient develops pulmonary edema and requires mechanical ventilation, you have to ask yourself, do I have the ICU bed? So in this case, you've given 20 per kilo, you examine him, the lungs are clear, the liver edge is not palpable, so it's not volume overloaded. So what will you do again? You repeat another 20 per kilo. So, are we making any progress? This is after this patient has gotten almost 60 per kilo in aliquots of 20 cc's per kilo times 3. So this is a case of hypovolemic shock. I will move quickly to another example here for the sake of time. Okay. You are in the emergency room and this child came in with this skin rash that has been there for a week. He has a fever, he's not eating well. In appearance, I will go over the assessment now for you. Appearance, he looks very lethargic. Work of breathing is very tachypnic, but he doesn't have any abnormal sound. There's no stridor, no wheezing. It's just tachypnic. When you look at the skin is very warm, and the cap refill is brisk. Based on the conversation we had in the morning, what kind of shock is this? What kind of septic shock is it? Okay. There are two kinds. In pediatrics, you're going to have a cold shock and a warm shock. Warm shock. The warm shock, the patient has fever, hyperdynamic circulation, meaning he's tachycardic, his blood pressure is low because his systemic vascular resistance is low, but he looks, on the skin looks well perfused, but that's just a fluke. So this person is 6 years old. Thank you, Kola. This person is 6 years old. Are you satisfied with his blood pressure? Anybody? No. How about what kind of rhythm is that? He's a sinus tachycardia, right? So in your primary assessment, this patient's pupils are reactive, he has good breath sound, but he's tachycardic, his pulses are thready, his capillary refill is prolonged. So you need an IV. If you cannot get an IV, you do an intraosseous. This is a slightly older child, you should be able to get an IV. So let's assume, for the purpose of this discussion, that you put in an IV. And by now, you have given in excess of 40 per kilo. Have you noticed any change in the vital signs? Anybody? What? I will go back to where we started from. Look at that. Here, the blood pressure is low, but the oxygen saturation is what? Normal, okay? Now, because you've given almost 60 cc's per kilo of fluid, so it still has low blood pressure, but now its oxygen is dropping. What will you do? Give more fluid? What else can you do? Yes? Anybody remember the conversation we had in the morning that if you are in a teaching hospital environment where you have all the support system, you can give fluid and give fluid. If you are somewhere where your support system is not very robust, you go straight to inotropes, right? But this patient has hyperdynamic shock. His temperature is, it's not showing there, but his temperature is like 40 degrees centigrade. So what vasopressor would you use? Norepinephrine. Fantastic. So you are doing norepinephrine. All right? I don't know if you can hear the sound. By this time, your patient is grunting, because his lungs are now filled with fluid, and in spite of being on norepinephrine, his oxygen saturation is now 80. We went from 95 to 88 to 80. What recourse? What options do we have? Anybody? Suggestions? Well, at this point, you probably have to intubate this person and provide mechanical ventilation. So that is the reason we were saying that if you don't have that resource, you have to be careful the way you manage this patient. Okay, this is after the patient was intubated and supported appropriately. You are a little bit happier. So I've given you two examples now of a cardiogenic shock. Okay, cardiogenic shock and of course septic shock. The last one I would show you here because of time. Let me exit out. This one is quick. Okay, this is a 12-year-old boy who was involved in a motor vehicle accident, was a front seat passenger. Then they rushed to the emergency room. This is the vital sign in the emergency department. What are you concerned about now? Of course, the oxygen saturation is low. You've done your initial assessment, but then during your primary assessment, you discovered that there were no breath sound over the right lung area. What do you think is going on? Tension pneumothorax, okay? This is an example of obstructive shock. With tension pneumothorax, you don't have to get an X-ray. You go straight to needle decompression, and then you can get an X-ray to put in a tube. So that is very important. That's what this is supposed to do. Okay. So following needle decompression, the patient's so that is an example of an obstructive shock from the tension pneumothorax. I think that is probably where I would stop this example. So we have hypovolemic shock, we have cardiogenic shock, we have obstructive shock. The take-home message is that for critical care, your assessment is important: initial assessment, primary assessment, secondary assessment. Your secondary assessment is just when you are taking your history. You cannot ignore a sick patient and be taking history. Thank you.
Please let's give him a round of applause. I think we're going to have a round two of this online, where we can all sit down in the comforts of our room and listen, because I was enjoying myself, but I know time is fast spent, and we're all sweating. We've come to the conclusion of the program, but before we close, I'm going to hand over to the IMSG president, Dr. Bode Williams, a few plaques for the speakers. Some were online, some were physical, but I'll just use one as a prototype. Maybe I will just use Dr. Kyle Adeboye, if he's still around. Well, I will just a prototype. We'll not present in absentia. We'll hand them over to you. So, at the 2025 IMSG Symposium, which took place today, Wednesday, the 12th of November, 2025. Is he here? Oh, okay. Yeah. Well, thank you. Okay. He went out. Okay, so so I'm going to hand over all the certificates to you, since you'll be taking them with you, so that we don't waste too much time. So, Doctor, should I continue the rest? Yeah. Okay. Fine. We'll take everything. I mean, in that. Yes. So, Prof, you're going to take everything. So we have another one. This is for Professor Rotimi Jaisimi. So on behalf of the Ibadan College of Medicine Alumni Association, we want to appreciate Professor Rotimi Jaisimi for a lecture eruditely delivered. Let's give him a round of applause, please. This is for Dr. Adeboye in appreciation of his lecture, which was eruditely delivered. Let's give him a round of applause, please.
On behalf of Ibadan College Medicine Alumni Association Worldwide, this award is presented to Professor Olugbenga Akigbola in appreciation of a lecture eruditely delivered at the 2025 IMSG Symposium today, Wednesday, 12th of November 2025. Thank you so much, everyone.
Thank you so much. And the last award goes to Dr. Associate Professor Olaleye. I saw his award now. Let's welcome a round of applause. Yep. Yeah, this is it. Yeah.
On behalf of Ibadan College of Medicine Alumni Association, ICOMA Worldwide, this award is presented to Dr. Oladejo Olaleye in appreciation of a lecture eruditely delivered at the 2025 IMSG Symposium today, Wednesday, 12th of November, 2025.
Thank you. And very quickly for our internal speakers, I'll call them, Dr. Jifini, ICOMA Worldwide. This plaque to you. You know, Dr. Jifini, please let me around. I thought it was.
Yeah, on behalf of Ibadan College of Medicine Alumni Association, ICOMA Worldwide, this award is presented to Dr. Kehinde Ojifini in appreciation of a lecture eruditely delivered at the 2025 IMSG Symposium today, Wednesday, 12th of November, 2025.
Dr. Kayode Adeboye is here. So just Dr. Kayode Adeboye, sir.
Yeah, on behalf of Ibadan College of Medicine Alumni Association, ICOMA Worldwide, this award is presented to Dr. Kayode Adeboye in appreciation of a lecture eruditely delivered at the 2025 IMSG Symposium today, Wednesday, 12th of November, 2025.
Let's give a round of applause. So the final award I'll receive on behalf of Professor Ikeoluwa Lagunju.
On behalf of Ibadan College of Medicine Alumni Association, ICOMA Worldwide, this award is presented to Professor Ikeoluwa Lagunju in appreciation of a lecture eruditely delivered at the 2025 IMSG Symposium today, Wednesday, 12th of November, 2025.
Thank you very much, sir. I welcome Dr. Olaleye to give some closing remarks as we leave. We are at the end of the program, and we should be closing in less than 5 minutes or less. Let's give him a round of applause. He's been our host. He's been sweating. We said we'll close at 5. Despite the hiccups, we are actually closing almost 4:45. I think we've tried. Let's give ourselves a round of applause, too.
Thank you, thank you. Thank you, everyone. Yeah, much appreciated. Wow, this is amazing. Standing ovation. Look at this. Thank you so much. Please take your seats. That's for all of IMSG and ICOMA and UMSA and all the organizers in the emergency medicine department. Thank you, guys. So I really just want to say a very big thank you to every single person present here. Thank you for your time. Thank you for bearing with us. If you think you are hot, spare a thought for me. Those of you already used to Nigerian heat, you can imagine how I feel in this suit here. Oh, that's lovely. So thank you so much for staying with us. I hope you found the symposium this year of benefit to you. You understand the importance of emergency care. We tried to create something that would make it so that you can participate. And I hope that you were able to go through the cardiopulmonary resuscitation, role play, and hopefully you've learned something. I do want to say a big thank you to the Ibadan Medical Specialists Group. I'd like them to stand up, actually. Lady Beams has already stood up. So please, a round of applause for Ibadan Medical Specialists Group UK. Yeah, it's absolutely amazing. Those physically present, our president, Dr. Bode Williams, our vice president, Dr. Abioye, and our first lady, Dr. Beams Williams. Thank you so much for traveling down and coming along to support this. There are a lot of IMSG members online as well. We're very grateful to you. IMSG has been a force for good, and I don't say that lightly. This symposium has been running for as long as I was a medical student, and that was 23 years ago. Some of you don't even look 23, to be honest. But there you go. So I remember IMSG coming, giving symposiums, inspiring us, and this is us here now talking to you, and it will be you next, coming here for the next generation. Can I have a big amen? So that's a prayer for you, because I know that you will pay it forwards as well. And it's great to see I think we're back on. So I was talking about the scholarships. I think it's a great thing that we're able to give and support the education of some of our scholars. And we want to encourage other alumni to think about this. I know Dr. Shikalu says you can give individual scholarships, you can support as a group. So whatever we can do, I'm calling on alumni who are online and everybody watching. Please, let's think about how we can give and support students in Ibadan. The economic climate is not smiling. So whoever we can help get them through education will be great. Regardless of your background, regardless of whether you shouldn't have to struggle just because you don't have money. So hopefully you got an alumni association that can support you. I want to say a big thank you to all our faculty, all the speakers who have given brilliant talks today. Professor Kingbola from the US, where is he? Has he gone out? Oh, he's gone, okay. So yeah, great lecture. We'll probably need an online session to probably go through all those cardiac arrhythmias he was showing us. Thank you to all our speakers, Dr. Jifini talking about the UCH experience, our online speakers, Prof. Jayesimi on sepsis, Dr. Kingboye, Kintunde, Adegboye Akintunde, who talked about, okay, what did he talk about? They're looking at me. What did he talk about? Airway management, Oshio, airway management. And then non-surgical, yes, no, let's give our full marks. Let's not, we give you full marks, well done. And I talked about surgical management of the airway. And we've had a lot of talks. Sorry? Which other talk? Phone a friend. Oh yeah, read it out. Yes. 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 Amazing. What's your name? Well done. So that's good. We will see you after. That was nice feedback recap. So well done. Thank you. I want to say a big thank you to Prof. Obajimi here. He's been phenomenal in helping to organize this. We have been on this for months on the planning committee, and Coma admin. We're really grateful, sir, for helping us. That's been fantastic. Lola Akiniti Ray and all the ICOMA admin were really grateful. we couldn't have done this without your support and, you know, the IT team, everybody who's helped serve to Eshegon. We're really grateful. Thank you. Another round of applause for him. So thank you to everybody online. I think we've come to the close of the IMSG Symposium 2025. Yeah, so a big round of applause to all of you. Yeah, so I think in closing, we would take some pictures. We're happy to interact with students. You know, just say hello, because I think it's important as well. If you feel you want to say hello to us, that's fine. But we want to take pictures with some of our scholars. So I would invite the Pouch 98 scholars. So these are scholars for my class, 2002. My class have been texting me, I want scholars wada. So please, Pouch 98 scholars, and we've got our Pouch 98 present here as well. Dr. Kehinde is here, present with us, Dr. Kehinde Kuti. She works here in primary care in UCH. I think I saw Dr. Ayeni earlier on and Dr. Yemisi. So please, we finished the meeting now, so please feel free to say hello to people. Thank you for coming. We're just going to take pictures and just chat, and then we'll leave. So thank you so much for coming, everyone. So Pouch 98 scholars, please, quick picture. Thank you, sir. Pouch 98 scholars, please come to the front. At least I've seen. I'll hang out with this guy. Pouch 98 scholars, please come to the front. Thank you, everyone. UMSA executives also come forward.